Morning, everyone. Good morning, and welcome to the Kennet Room at County Hall for the February meeting of the Health Select Committee. As always, just a reminder that today's meeting is being broadcast live, so that prompts me to put my phone to silent. If others would do the same, that'd be great. So I'll move on to item 1 on the agenda. Apologies. Stuart, I understand we have a couple of apologies this morning.
Yes, Chair.
Cameron,
We've received apologies from Councillor Anthony Picknell and Councillor Pauline Church.
Great, thanks. And I understand we don't have subs for either of those, so we're slightly down in numbers this morning. Item number 2 on the agenda, minutes of the previous meeting. Is the committee happy for me to move that the minutes from the meeting held on the 18th of January? Mike?
Thank you, Chair. Could I just ask that the minutes are amended to reflect the fact that I did actually attend, albeit virtually?
Yes, certainly. I'm sure we're able to arrange that. So noting that amendment, are we happy to move that the minutes would be from the meeting held on the 18th of January 23 are a true record? Yeah, could I have a second of that? Oh, Irene, sorry.
Whether we can schedule an update on the maternity report on maternity services for them to report on how their strategies have worked.
Yes, certainly. Would you mind raising that in the forward work programme
Okay.
part of the agenda? We'll happily incorporate that in. So I've moved that the minutes from this meeting held on the 8th of January 23 are to record. Could I have a seconder for that, please? Howard, thank you. Any objections? No, that is moved. Great. Item number 3, declarations of interest. Are there any declarations of interest or dispensations as granted by the Standards Committee? Gordon. Oh, fine. Okay. Thank you, Gordon. Thanks. Grant. So, yes, Claire Cape will be attending, but he's just running slightly late. I'll move on to item number 4 on the agenda, Chair's announcements. First of all, on behalf of the committee, I would like to start by extending our condolences to the friends and family of Helen Jones. Helen contributed a huge amount to this committee and has been a huge support and help to us all with her informative briefings and updates, and we will miss her greatly. So I'd just like to express our deepest sympathy to Helen's family and friends and colleagues. The meeting with the representatives from Baines and Swindon Scrutiny, members may recall at November's meeting, the committee recommended that the chair and the vice chair meet with our counterparts from Baines and Swindon Borough Councils to discuss the programme of health and social care integration and opportunities for collaboration. Both councils, Swindon and Baines, have elections this May. So we felt that we would put those discussions on hold until June once things have settled down post those elections. So hopefully the committee are happy with that. Just an update on briefings. There are 2 briefings for committee members coming up in March, providing an opportunity to scrutinise reports before they're received by Cabinet. Those are on the 10th of March, Carers Support Strategy and Service Commissioning, followed by on the 17th of March, Good Lives Alliance Framework Retender. All members should have received a calendar invite for these briefings, and I'd encourage you to attend and participate if you are able. Just on quality accounts, as you know, every year we receive quality accounts from health providers for review, and we're expecting to receive those this May, and the chair and vice chair will be reviewing those and be reporting back to committee. And finally, I'd like to pass on our congratulations to Emma Legg, who has recently been appointed as Director for Adult Social Care, with the Director roles for Living Well and Whole Life Pathway having been combined into one. So congratulations to Emma. Moving on then to item number 5 on the agenda, public participation. I'm not aware of any today. Is that correct? Fine. Great. In which case, we'll move on to our first sort of main item, which is the Joint Strategic Needs Assessment for 2022. I'd like to welcome Kate Blackburn, Director for Public Health, to present an overview of Wiltshire's Joint Strategic Needs Assessment, or JSNA. The findings will be a reference for the committee to understand how we can meet the needs identified in the assessment. So I'll hand over to Kate for the presentation and then we'll have questions. Thanks, Kate.
Lovely, thank you, Johnny. Morning, everyone. It's nice to see you all. Some faces I wasn't expecting to see. Hi, Mary. I'm going to give you a flavour of the Wiltshire Health and Wellbeing Joint Strategic Needs Assessment. It really gives us all sorts of data and indicators on our population, so really important for Health Select Committee members to be fully sighted on what we're finding currently. It really helps to look through the health inequalities lens, so we're not just looking at Wiltshire as one big mass of people, because we've got so many different communities within Wiltshire. There is a huge amount of work that goes into building the JSNA. Lots of our partner organisations contribute, lots of other council directorates, so there'll be different themes that we'll talk through. And really this morning, it's just to give you a flavour of the contents, because this could take days, and I promise I'm not going to take days. We've got about 30 minutes. When we've kind of run through the headlines before, some of the data can really stop people in their tracks. So if you're happy to, if you can note anything down whilst I'm talking, because I'm going to ramp up the speed when we get to the slides, just so we don't leave you all here till tea time. If you can jot anything down, any queries you have, and I'll take them with me, unless they're quite simple to deal with now, so that we can unpick them for you, because there's hundreds of indicators that sit behind these headline slides. I think the other thing just to mention is that this year we're turning the indicators into stories. Not everybody loves graphs and infographics. And actually, as you know, stories are a fantastic way of really getting across some of the important messages for our population. So Christine's story is the first one that's been written. That's very much looking at the data through a health inequalities lens. That story has now been filmed and is on the Wiltshire Intelligence website. We'll make sure that all committee members get the correct links to the JSNA and then also the stories. But there's a whole library of stories being put together. So colleagues from the Acute Trust, from primary care, from our substance misuse services have asked if they can use the indicators relevant to their services to develop these stories, which really do help to capture the imagination. And through Christine's story, it's already kicked off a work stream between ourselves and our ICB colleagues, really looking at how we use population health management data, the data we can collect through primary, secondary care services, to really target some really important interventions in a way that communities and individuals can take them up, rather than just reminder text messages, which sometimes can be more of a barrier for somebody coming forward for an essential service than anything else. So we'll kick off with next slide, please. If you see me winking, it's my secret signal to my slide helper at the front. So we're going to kick off, and I will apologise. I'm going to be looking at my screen a lot on this because I don't want to shortchange you, and there's a lot of data to get through. So please feel free to stare at the screens rather than me. That would be really helpful. In Wiltshire, we've got a population of just over 510,000 people. It's a roughly equal split between men and women. But the key thing of interest, and this will not be news to this committee, about the Wiltshire population is the way in which our population is growing and ageing. So the population pyramid, that's the pyramid in the top middle of this slide, that shows you male and female proportions by 5-year age band. And you can see currently that largest proportion of people in Wiltshire are aged 50 to 64. Now, the dotted line, which is quite faint on these slides, but when you get them around in the pack, you'll be able to see them a bit better. That just shows you where those proportions of age bands are going to be by about 2040. And that really illustrates the large increase in people aged over 65 in Wiltshire, but equally a significant reduction in the proportion of people of working age in the county by 2040. Now, both of these things are really important for a number of reasons, but if we think about it simply, we know that older people tend to have more health conditions and can require more services across health and social care. And we also know that we struggle to recruit even now to some health and care posts and lots of other types of employment roles within the county. So with a reducing working age population, this can really have an impact and compound those issues we're already seeing, pressures in services even further. So in a bit more detail, by 2040, we expect to have seen the over 65 age cohort increase by 43%, with the over 85 age group increasing by 87%. If we think about what we're already seeing in terms of NHS services, social care services being extremely busy all year round, and that's with the demand and capacity we have now, factoring that growing ageing population, factoring that shrinking working age population. These are things we all must be really mindful of when we're thinking about how do we prepare our services and plans for the future. And then really just to finish off on this slide, I really want to mention inequality. Those are those avoidable, unfair, systematic differences in health between different groups of people. We have in Wiltshire what's called lower super output areas. They're just small areas of geography. We've got 285 of them in Wiltshire. 8 of those are in the 20% most deprived areas nationally. Those 8 are classified as urban, city and towns, and they're located in Trowbridge, Chippenham, Salisbury and Melksham. Now, the total population from Wiltshire that lives in these 8 smaller geographical areas is about 14,000 people. And when we compare that to the Wiltshire population, what we see is a higher proportion of young people aged 0 to 19 that live in these areas, and a lower proportion of those aged 65 plus. So again, whilst these are overview slides, just to really highlight, we can dig into the detail a bit further, and we must, so that we're not just looking at Wiltshire as an average. We really need to start picking into things. Could we pop onto the next slide, please? That would be lovely. So I'm going to move us on to talk a little bit more around life expectancy. Wiltshire as a whole county is placed in about the least deprived 30% of local authorities in the country. Average life expectancy for women, about 84.5 years. Men, it's almost 81 years. So that's pretty good. However, when we look beneath the average for the county and check it by deprivation again, we see that hidden inequality showing us about a 5.5-year difference in life expectancy for women who live in the more deprived areas of Wiltshire compared to those in the least, and a difference of just over 7 years of life for men, depending on where you live. If we look at healthy life expectancy, that's in the top right-hand corner of your slide. And basically, this is the length of time someone can expect to live in good health. The gaps are even more apparent for women and men in the least deprived deciles when we compare them to the most deprived. So data here demonstrates nearly 20 years difference for both men and women in the length of time they can hope to live in good health. Now, if we think back to the previous slide, where the number of people of working age are going to be reducing into our county, and then we have to add in the proportion of people who may be in poor health and not able to work from their early 50s, again, we're really compounding those workforce issues across all of the areas in the county. So understanding the numbers and the causes of death and how these are changing over time is really important for us in terms of planning future services, but also really looking at those preventative services and interventions. Now, cancer and cardiovascular disease remain the highest diseases. They continue to cause over half of all deaths in Wiltshire. They are responsible for the majority of deaths of people aged under 75 as well in Wiltshire. The rates of premature mortality due to cardiovascular disease in men are more than double than those that we see in females in the county. That's a trend that's reflected nationally, but again, really needs to be considered when we're starting to think about prevention and treatment. Are we really targeting the types of services and interventions that we need to in the right places? When we look at age-adjusted rates of preventable deaths in Wiltshire, we have just over 3 times, it's 3 times higher for men living in our more deprived areas than it was for men in our least deprived areas, and almost 4 times higher for women. What in reality that means is we have a rate of deaths that are considered preventable, so preventable deaths, but a rate being 3 times higher for men and almost 4 times higher for women across Wiltshire, depending on where you live. I think that's a really stark indicator. If we can pop on to the next slide, please, that would be lovely, and we'll have a little bit of a look into disease and ill health. Now, this is the section of the JSNA that I find it really hard to be succinct about, so we're going to be really strict. I'm only going to pull out a couple of points, but this section in full covers everything from coronary heart disease, hypertension, stroke, COPD, asthma, diabetes, dementia, chronic kidney disease, infectious diseases, sexually transmitted infections, unintentional and deliberate injuries. There is an absolute plethora of information within this section online, so please do check it out in your own time. And again, as a committee, if there are certain areas you think, gosh, that's really interesting, it would be helpful to have somebody come and talk through that. Obviously, we'd always be very happy to do that. So I'm going to stick with hypertension. Hypertension, diabetes and asthma were the most prevalent conditions in Wiltshire. Prevalence of hypertension in Wiltshire is actually higher than that recorded in the South West region, and it's higher than we see in England as well. And according to the British Heart Foundation, about half of all heart attacks and strokes in the UK are associated with hypertension. So it's a really key indicator for us. We also know that hypertension is more prevalent in our more deprived areas in the county. Now, the risk of developing high blood pressure, hypertension, can be influenced by a whole range of factors. Socioeconomic circumstances is one of those, so living in areas of higher deprivation. But smoking plays a key role, weight and diet, physical activity, sleep deprivation, and ethnicity. So people of Black African or Black Caribbean descent are at an elevated risk of developing hypertension. So there's a whole range of reasons as to why somebody may be more at risk of hypertension, and we just need to really be understanding across the county where we can have the biggest impact in helping to reduce that. So when we turn to diagnosed cancer incidence rates in Wiltshire, they are again consistently higher in men than in women, and again higher in our areas of higher deprivation. And again, that mirrors the trend that we see in the UK. Similarly, the types of lifestyle activities, indicators that can affect whether or not somebody is at high risk of cancer really mirror those for hypertension as well. So how do we look to combine then, if we know that we have higher rates of hypertension and cancer in certain parts of our population, how can we as a system look at better ways of really identifying those cohorts and doing things about it? So when we think about disease prevention, there are some services and actions that really help. You will know this as the committee: vaccination and screening, absolutely critical. The data, the most current data we have shows us that for cervical and breast cancer screening levels, they've reduced in Wiltshire over the last 2 years, probably as a result of the pandemic. However, for both, the uptake has remained consistently lower in the more deprived areas of the county. And again, it's these types of data points that can alert us to the differences in the population. We should be asking why each time, not simply relying on reminder letters or reminder text messages to believe that that will enable somebody to attend. As I said at the beginning, a reminder letter can sometimes do the absolute opposite to what we want it to do. Hi, Claire. And then just finally on this side, I just wanted to touch on hospital admissions due to mental health conditions in our under 18-year-olds. In Wiltshire, those rose to their highest recorded rate for 5 years in 2020-21. There had been a period of fluctuation before then. We think the highest rate could be attributable, at least in part, to the impact of the pandemic. But in 2021, we had around 100 hospital admissions recorded relating to mental health conditions in the under 18 age group in Wiltshire. That's a significantly higher rate than is reported in England, but actually lower than in the southwest. So there is definitely something about the southwest, and we've seen that in other indicators such as self-harm in young people. So if we can pop onto the next slide, please, and we'll just have a little look around alcohol, drugs and smoking. So just to give you some examples really of alcohol-related harm in Wiltshire, that includes 176 people who were killed or injured in drink driving incidents in a 2-year period. We had over 6,500 hospital admissions in 2020-21 and 565 new cancer cases with 174 deaths in 2020. Now, alcohol-specific hospital admissions are those in which the hospital admission was wholly due to the effects of alcohol. Wiltshire, like the rest of the country, has seen a long-term increase in alcohol-specific hospital admissions. Rates in 2021, however, were slightly lower than in the previous years. Again, we believe that's likely due to the pandemic and the effects that had on overall hospital admissions. There is some variation by age group, but in 2020-21, in general, men in Wiltshire were much more likely to be admitted to hospital with an alcohol-specific condition than women, and men aged 45 plus were at particularly high risk. So the little graphic at the bottom left-hand corner of the slide where you can see some lines and then a man at the top and a woman at the bottom and the groups in the middle. What we see is this real gender imbalance, and we see it even more in our areas of higher deprivation. So the little graphic at the bottom, you can see that in our least deprived deciles, the alcohol admissions for men, women, everybody joined together are sort of pretty similar. As we move across into the more deprived deciles, you can see just how much higher admissions are for men in those parts of Wiltshire. We know that smoking is the biggest single cause of preventable death and ill health in England. It's a major risk factor for many of the diseases that we've covered, such as lung cancer, COPD and heart disease. And it's also associated with a number of other cancers in other organs. Now, there are substantial inequalities in smoking prevalence in our county. Young men, people living in more deprived areas, and particularly people suffering from mental health conditions are at notably higher risk. Reducing smoking levels is a key priority for the whole system, and having a smoke-free Wiltshire is really something that we aspire to. Adults with long-term mental health conditions are estimated to be more than twice as likely to smoke than the general population, and people living in those neighbourhoods in Wiltshire in the most deprived areas are also at a really higher risk of smoking. And again, we see that then correlate when we see the higher rates of mortality in certain areas. So we're going to whiz us on to the next slide, please, which should bring us on to our education and employment as a focus. I think this one's really interesting. So levels of employment in Wiltshire rose quite notably in 2021 compared with the previous year. And again, that followed a period of fluctuation. Now in 21-22, 82.5% of economically active 16 to 64-year-olds in Wiltshire were employed. That's higher than levels in the southwest. It's also higher when we compare ourselves with our statistical neighbours, and it's also higher than the rates that we see in England. Now, across all age groups, Wiltshire has higher employment rates than the southwest England and its statistical neighbours. However, the average earnings paid by workplaces based in Wiltshire for both full and part-time workers is below the average resident pay. So for residents who are able to travel outside of Wiltshire, there is better earning potential. But with the cost of living crisis squeezing finances, those who live and work in Wiltshire may be more adversely affected. And then you have this cycle of not earning enough to be able to afford transport, be that private or public, so having to work locally where we know that the average earnings are lower. We do see a difference in long-term sickness and gender in Wiltshire. A higher proportion of females are economically inactive because of long-term sickness when compared to men. And that actually is in contrast to both the southwest and England. So that's a different pattern that we see in county, which is going to be interesting to unpick. If we look at our young people aged 16 to 17, those who are classed as not in education, employment or training, the NEETs, over the last 4 years in Wiltshire, that's been reduced, the proportion, to 7%, which is now comparable with the southwest. It had been almost double that amount a few years before. So we can really see that when we have certain indicators and we can hone in on that data and work with our partners, you really can change outcomes for different parts of our population. I think we've really got to see the positives in that and make sure we do that using this GSNA going forward. Eating well is fundamental for children and young people in terms of their physical health, their learning and their development, and healthy free school meals can help to reduce inequality so that all children can learn and thrive irrespective of their background or circumstances. Now, children and young people in state schools in England are eligible for free school meals if their parents are in receipt of one of a selection of benefits. Additionally, all children in reception and Key Stage 1 are entitled to a free school meal regardless of household income. Now, in Wiltshire, as in other areas, the proportion of pupils eligible for free school meals has risen steeply over the years. It was 7.3% 4 years ago, it's now 14.4%. Now, the proportion of pupils in Wiltshire actually taking their free school meals has also risen. So that was 5.8% 4 years ago, and those percentage now taking is 10.9%. Now, for Wiltshire, the gap between those who are eligible for and then those who actually take their free school meals is about 3.5%. This was lower than the southwest, our statistical neighbours in England, so that's good, but it's potentially worrying because we have a growing proportion in Wiltshire who are not taking their school meals. So actually it used to only be 1.5% and now it's just over 3%. So there's really something about how do we enable families to take up the opportunity of their free school meals for children. So if we pop on to the next slide, which should bring us to housing. Lovely. I think it's really fair to say housing is a fundamental part of people's lives and really can impact both physical health and mental health and well-being. Now, housing in Wiltshire has been consistently less affordable than its geographical comparators over about the last 10 years. In Wiltshire in 2021, it was estimated that full-time employees could typically expect to spend around 10 times their annual earnings on purchasing a home. That's slightly higher than England, which is just over 9 times. House prices and annual earnings have grown disproportionately over the last 10 years. I'm sure this won't come as news to anybody on the committee. From 2011 to 2022, the median house price has increased by 48%. whilst median annual residence-based earnings have increased by only 14%. 2022 continued to see that rise in house prices, and again, with the cost of living crisis, it's expected that gap between house price and annual earnings will continue to grow. Now, over 65% of households in Wiltshire are estimated to be owner-occupied, either outright or with a mortgage or loan, and that number has been increasing over the past 5 years due to the increase in households that are owned outright in Wiltshire. Now, whilst living in owner-occupied housing has a number of benefits, it's really important to note that an increase in older people living in owner-occupied housing has potential financial challenges in terms of maintaining the home, keeping the home safe. Without proper maintenance, households can become cold, damp, and potentially hazardous to health. And there may also be the need to make adaptations to the house as physical ability may change, which could be difficult for people with limited funds. And without those adaptations, people can become less independent. Now, the English Housing Survey found that the number of people aged 45 to 54 in England living in the private rented sector is increasing. The private rented sector has some of the worst housing conditions, as well as being less affordable and less stable. Now, as this group of the population ages, it's likely we're going to see a much larger proportion of our older population living in private rented households, with a number of potential physical and mental health impacts from living in unaffordable housing in poor condition. If we look at the EPC ratings, the energy ratings across the different housing tenures in Wiltshire, which helps to show us how energy efficient a property is, social rented dwellings have the highest proportion of EPCs rated A to C, which is the most efficient at about 44%, and that's likely due to sector-specific initiatives that have very specifically focused on housing standards. Owner-occupied properties have the highest percentage of properties with the least energy efficiency ratings. So I've already mentioned we've got a large proportion of owner-occupied households owned by people aged 65 and over. Having a less energy efficient home could mean that an older people is living in their owner-occupied home, which would be potentially colder, more damp, leading to more ill health exacerbation. And then just to touch briefly on homelessness. So the definition of homelessness means not having a home. You're homeless if you've nowhere to stay and you're living on the streets, and you can also be homeless if you do have a roof over your head, but you are, for example, sofa surfing. Homelessness and the fear of becoming homeless can result in ill health and can severely aggravate your current health conditions. Now, in 2020-21 in Wiltshire, nearly 25% of people applying for homelessness were aged 16 to 24. Homelessness is more likely to occur amongst populations who are already experiencing inequalities. The most common support need of those owed a prevention or relief duty due to homelessness is a history of mental health problems. That's then followed by physical ill health and disability, and those at risk of or experiencing domestic abuse. So I think that's probably my last slide. As I said, it's a proper whistle-stop tour, and we could spend hours on each section, and I'd love to. But as I say, I'm really happy to take any questions. I may not be able to answer them all for you now, but we can certainly take them away.
Okay, thank you very much. That was a really clear presentation and really informative slides, so thank you for that. We've got a question from Pip. You in?
Thank you, Kate. That was very useful, especially the statistics. Have you, in the full print, have you got the ones for the individual areas against your? And secondly, can we have a copy of all those slides, please? Thank you.
Yeah, you can absolutely have a copy of all the slides. I'll make sure you all get the links that then take you to the data behind it, which is where it's broken down by areas of deprivation. And I should have mentioned, so the community area JSNAs, the development of those has just begun. We hope to publish those probably October, November, which I know for local area boards and communities is really helpful. The team, again, will be coming out to discuss with a number of different people and partners how best they can be developed, but then also shown. So, for example, the stories that we're using for this JSNA, and I wish I could tell you Christine's story. There is a link, there is a film, please watch it. I think it's only about 10-15 minutes long, but it just brings the data to life in a way that me sitting here really doesn't do it for you.
Yes, locally, that's the statistics are what influence people locally. You can tell everybody what our population is in Wiltshire, but they always want to know how does that affect Warminster, Westbury, wherever it is. So that's good to know, because our last JSNA, which is hopelessly out of date, did have one for each community area. Thank you.
Thanks, Pip. Any further questions? Claire and then Gordon. Councillor Kate. Are you in? There you go. That's on. Ooh, that's off again.
Hopefully that'll work. Yeah, thank you. And apologies for being late. The bus got held up by some horses and various other entertaining things. So I'm sorry to have missed the beginning. I was a little bit interested when you talked about smoking. What's been the overall direction of travel on smoking? Have we seen some improvement over the last 5-10 years? Thank you.
Yeah, we have. It's down at about 11% at the moment. The kind of figure for the overall population fluctuates a little bit. What we haven't really seen any movement in is people with a serious mental illness who smoke. The other group, which is really key for Wiltshire, is what's known as the routine and manual worker category, particularly where English isn't the first spoken language, and we see very high rates of smoking there. And I'm sure you'll all be aware as well in terms of vaping and the conversations that are happening nationally at the moment, because vaping is absolutely a legitimate mechanism to stop people smoking tobacco, but obviously there's a real concern about just how many children and young people are now taking up vaping who were never smokers in the first place. So smoking is a real key for us, and it's one of the priorities for the ICB as well in terms of health inequalities, and also just to say, because I think you probably would have missed it, Claire, and I'm not sure how clear I was, but all of the JSNA data we're now linking with our colleagues in the ICB around their population health data, so we can really drill down into, we know this is affecting the population, now we know who it's affecting, and now we can actually go out and have conversations, a bit like we did with the vaccine outreach work, so that we're not just saying, oh, well, you can come here and we'll sort it out. It's actually, why is this an issue? What are the barriers? How can we really work together to support you to be able to make choices that will keep you healthy for longer?
Thank you, Johnny. I've got a couple of questions. Hi, Kate. First of all, thank you very much for a really good presentation. And secondly, could you remind me how often we refresh the JSNA?
So when we don't have a pandemic, so we used to do three different types of JSNA historically in Wiltshire. So the health and wellbeing JSNA, which is this one, the community area JSNA, which is really important for Wiltshire, and then there also used to be the CCG JSNA. The CCG JSNA is no longer necessary because we're working so closely with our NHS colleagues now that actually the health and wellbeing JSNA captures the information that we need. So it will be on a 2-yearly cycle. So it will alternate between health and wellbeing and community area. And now that we've got different types of software available to the team, so things like Power BI, some of the really key indicators that I know people find so useful around life expectancy, healthy life expectancy, some of those key things, they should just auto-populate. So once we get the national indicators coming through, it won't be set. At the moment, it's a really long process to be able to deliver the JSNA. It's about 9-10 months work of 3 people just solidly working. With the new data tools that we'll get, hopefully that means that some of those indicators will just update as soon as the national data is available.
Well, you actually preempted my next question really was, how do we measure the trend? In a year's time, for instance, could you come back and let us know what that trend is looking like?
Yeah, so every indicator in the JSNA should have a trend over time, and it should also be compared to either regional, national, or our statistical neighbours, so that we can monitor where we've been, where we're going to, and what that trajectory is looking like. The pandemic gives us funny blips in different places, but actually what we're seeing now is some real change in behaviour and change in indicators since the pandemic, which I think is going to take a couple of years to play through, but absolutely we're always delighted to come back to committee, and all of this data is being shared across the system. It's been to our Integrated Care Alliance, it's been to the Acute Trust, it's been to primary care, substance misuse treatment services. So it's really exciting for me because the team have put together a fantastic resource, and I feel that probably for maybe the first time it's being used in the way that it really should be to help inform our priorities and the commissioning of services going forward.
Well, that's good news, really, because this is about Wiltshire, and we should really be interested in those trends. So it'd be good to see how they're changing. Thank you very much.
Thank you, Chair. I just want to take you back to an earlier slide, one of your first slides, where you had the 20-year difference between those in deprived areas and those that are not. Why such a huge gap? I mean, that is huge. That's quite horrifying. And I'm going to sound very naive here, but whether we regard healthcare provision as being adequate or not, I assume it's fairly uniform across the county. So I'm interested to know why that 20-year difference.
Yeah, so that's the healthy life expectancy. That's the difference in healthy life expectancy. So that's a self-reported measure, but it's remained kind of consistently there or growing over the last few years. You're absolutely right. Healthcare services, all of our public sector services are universally available at the point of access. However, the point of access can be really challenging depending on who you are, where you live, what your previous experiences have been. And I think that's one of the things we've learnt so much about from the pandemic is how we've been, if we just focus on the vaccine uptake of the COVID vaccine, it's been fascinating to see how different parts of the communities were able to access universal services, how for others it was almost completely impossible, but we had no idea why until we went and had the conversation and then really understood actually what the barriers were, what could be most beneficial. Really working with some of our workplaces, some of our bigger companies in terms of, we've had outreach vaccines go into some of the bigger workplaces where it would be very difficult for people on 0 hours contracts to take the time to go to a vaccination centre. So it's, on the surface, it seems as if there's a universal offer for everybody, but actually when you unpick that, it's not. And that's where I think you see the biggest inequality. And also because it's, a self-reported measure, I'm interested to see over the next couple of years how that starts to shift and move, given there has seen, for the population, it's been sort of crisis after crisis after crisis, but it is a big gap. It's bigger in other areas. Yeah. And actually life expectancy, the gap in life expectancy in other areas, again is bigger, but I think a 7-year gap in life expectancy is big enough in Wiltshire.
Thank you. Question from David?
Thank you. Thank you very much. Fascinating presentation. So one massive sort of question, which is, as a relative newcomer, can you explain to me how this informs response? How does this get translated into action? Have we done this needs assessment? We've got various reports coming up later in this meeting. Will we see these needs showing up there? I see it's Wiltshire-wide rather than BSW. So how does it feed into action planning? And I've got a couple of very specific ones, but that's the big one.
Okay, we'll do one at a time, otherwise my memory won't cope. I probably should have said at the beginning, the JSNA is a statutory requirement of the Health and Wellbeing Board, so that's why each local authority area with a Health and Wellbeing Board will have one of their own. It also wouldn't make sense to combine ours with Baines or Swindon because we have such different populations just within Wiltshire that if you add the other two areas on, actually you could really mask some of the areas of deprivation that we have in Wiltshire, so that's really important for us. The JSNA should be used by all parties in the Health and Wellbeing Board to help inform their commissioning decisions. And as I said, I think previously that was done to different levels of success, across the piece. I think at the moment, the JSNA has been used to develop the new Health and Wellbeing Board strategy, which David is here to talk about on the next agenda item. That's being used to help drive the Integrated Care Partnership strategy and the Wiltshire Integrated Care Alliance. So many acronyms. The Wiltshire Integrated Care Alliance then will have a delivery plan to deliver what's in that ICP strategy. So all of the data and the information in the JSNA is driving all of those larger strategic documents across the piece now to make sure that we are focusing our efforts and our energies where they are most needed.
Great, thank you. And the couple of specifics, one was healthy life expectancy. I just wondered if you could talk a bit more about that and how you define it. And I saw that, I think for women it was saying it was 65. And for men it said it extended into state pension age at 66. I was wondering, is that extending sort of down? I didn't quite understand what that meant. Can you say what healthy life expectancy is and what it is for the men and women?
Yeah, so as I said, it's a self-reported measure. So, with life expectancy, that's based on very hard and fast rules of you're alive or you're dead. Healthy life expectancy is subjective, really, and it's a survey that goes out across the country and is completed by individuals. But what it does over time is it can really help to show a trend in our population, and it's really useful to be able to look back in terms of, if we have a greater gap in healthy life expectancy in women than in men, is that because actually women are generally better at reporting their health conditions, at seeking help, at being happy to talk about it than men are, when we see that actually, 4 times as many men are at risk of cardiovascular disease when compared with women. So it's a useful tool, it's a good indicative tool of how people are feeling in the communities, but it's not based on kind of cut and dried medical information.
Just finally, if I may, Chair, on the statistic about homelessness being most prevalent among 16 to 24s, that really sort of didn't totally surprise me, but it jumped out and reminded me. How would that be interrogated, as it were, and taken forward? And how do we seek to address that issue? I know you had a bit of a breakdown with that as well. I wasn't quite sure whether that was just the 16 to 24s or all homeless people, but how are we sort of going to get after that, as it were?
So I think again, all of the information in the JSNA is being used by other services. I'm very aware that Emma sat behind me with her housing responsibility hat on. The JSNA can give you the data and the indicators that we get through national data, local data, as to what we're seeing impacting on the population. A lot of our services will already own that data and know that data and be using that to inform the decisions they're making to affect change where it's most needed. So I think I'd probably say it's similar to the repeat answer, is this is the data that helps to drive those conversations, but our services will have even more granular level data that they're using.
Thanks, David. And just kind of following on from that, I'd hope that the JSNA data feeds into the local plan preparation in terms of assessing the type of housing we need, and as we plot the future. And I see Emma's nodding at the back there, so yeah, it's great. And then just a question from me, possibly one for the next item, Kate, but you mentioned that the JSNA is sort of reviewed every 2 years. But I know that the health and wellbeing strategy that the JSNA informs is sort of a 9-year strategy. What flexibility is there? So if some dramatic trend emerges in, say, 2 years' time, what flexibility is there for the strategy to respond to that?
So I'm sure David will comment on this, but I think the health and wellbeing strategy, I think any plan that a system makes is never set in stone. We have to be adaptive, we have to be flexible. But I think what we do is we write the health and wellbeing strategy based on very good evidence-based trends that we've seen over time and what we know is impacting on the population now. And the 4 different sections within the Wiltshire JSNA gives us real flexibility to target where we most need to. But I'm sure David will tell you more eloquently than me.
Thanks, Kate. Any further questions for Councillor Kate?
Yeah, thank you very much. And it just occurred to me, you mentioned post-pandemic quite a bit, and I just wondered if there's anything in here that looks ahead to, God forbid, another pandemic, because it could, we knew that we would have a pandemic at some point, so we could well get another one. So I just wondered about that. Thank you.
Yeah, I think everyone's very aware. Just because you've had one, they're not like buses. Well, they probably are like buses. You don't get one for years and then 3 come along at once. Yeah, just because we've experienced one doesn't mean that we're any less at risk of experiencing another. That's not something that the JSNA would capture, but it's absolutely the work that carries on with the Local Health Resilience Partnership, the Local Resilience Forum, and all the planning through our health protection team. So it's not in here, but it's absolutely all in preparation.
Thank you. Any further questions from the committee? No. In which case, I'll move that we note the content of the Joint Strategic Needs Assessment 2022, that we ensure the findings of the JSNA 2022 informs the work of this committee, and to review the trends for Wiltshire in 12 months' time. I've said to Pip, thank you. Any objections to that? Great, that's moved. Kate, thank you very much. Oh, Gordon? You second. Oh, great. Okay. Thanks, Kate, very much for a great presentation. It was very informative. And with that, we move on to a related item, the draft Joint Local Health and Wellbeing Strategy for 2023 to 2032. So the next step after the JSNA is to plan how to tackle the issues highlighted in the assessment. David Bowater, Senior Corporate Manager, is now going to set out how the draft Joint Local Health and Wellbeing Strategy and Consultation Plan aims to achieve that. So David, I'll hand over to you and then we'll open up for questions.
Great, thank you, Chairman. I think you've all had the paper and hopefully you've had a chance to read it. And I'm going to ask Julie to put it on the second slide, if that's okay. So I'll speak to that one in a moment. Just to talk you through the process of how it was put together, we had the JSNA, as Kate's spoken you through. So that's provided the evidence base for this strategy. We've also got the statutory guidance from government, and there's been additional guidance on the roles of health and wellbeing boards, which came out last autumn. So that's really helped clarify the board's roles and responsibilities, but particularly in relation to the new integrated care system and the responsibilities that sit at system and place level. So in December, the Health and Wellbeing Board had a workshop which had a very similar presentation from public health colleagues then, which informed breakout groups and discussion. I was really pleased with the outputs of that discussion. I have to say, it's not always easy to turn those into a strategy, but for one reason or another, the aims and ambitions fell out fairly readily from those discussion groups. And I've been assisted by a steering group of colleagues from the NHS and colleagues from across the council, public health, adult social care, children's social care, and mental health, learning disabilities teams, as well as Healthwatch Wiltshire, who've all played their part in drawing together the draft, which is before you. There are 4 guiding themes in the strategy. The eagle-eyed amongst you will notice that they continue the themes of the last health and wellbeing strategy. They're also the same as the guiding themes within the council's business plan. Just if you haven't got that far in the papers yet, they are tackling inequalities and increasing social mobility, their prevention and early intervention, localisation, connecting with communities, and integration and working together. So the strategy broadly groups what we're planning to do under those themes. So those are medium-term aims. This is a strategy, it's not an action plan. So it doesn't list everything that all the organisations involved on the Health and Wellbeing Board are going to do to improve health and wellbeing. This is a strategy that focuses on where working together is required. So you won't see everything that Kate's team are going to do in there, for example. There's a public health service delivery plan that does that. This is about where teams are going to work together to deliver. So yeah, it's not everything everywhere at once. In terms of delivery, if you could go on to the next slide, please. Just want to, the one before. That's the one, thank you. So in terms of delivery, Kate's touched on that both the JSNA and the Joint Local Health Wellbeing Strategy are meant to inform the activities of commissioners. There's also a responsibility for the integrated care strategy to take into account what the health and wellbeing strategy says. There's an opportunity for the Health and Wellbeing Board to include a statement of compliance in the ICB's 5-year joint forward plan, which is going to come to the Health and Wellbeing Board at its next meeting. So that's really where the rubber hits the road in terms of delivery. I've touched on the fact that this strategy also aligns with the business plan. So there's another connection to delivery there. And the slide you have up on the screen there talks about, I kind of think of it in terms of lines of defence to make sure that this actually happens. So one of the other mechanisms touched on there is the ICB's annual report, and the ICB has to consult health and wellbeing boards on its delivery, and has to include an assessment of how it's delivered the health and wellbeing strategies. The other thing that this includes for the first time is that the Wiltshire Integrated Care Alliance, which is the officer group which brings together the NHS and council teams in terms of planning transformation activity, that work programme for that group is going to be set by what's in this strategy, and the ICA will report to the Health and Wellbeing Board on how it's delivering against each of those ambitions in the strategy. So that's a bit on the process, that's a bit on the content. Where we are now, the Health and Wellbeing Board has agreed this for consultation. There's a survey which should also be in your packs as well, and the questions are included there. There's an opportunity if you want to respond individually to give me individual responses by the 15th of March. And then at the end of March, Health and Wellbeing Board will meet again and consider the consultation findings. One other thing I want to say, I know your next item's on integrated care strategy. This is an iterative process, so we're doing this in tandem. We're working with colleagues in the NHS, and we're appreciating that there's going to be new information coming in at the same time. Baines and Swindon are also reviewing their joint local health and wellbeing strategies. So we're going to have to be fleet of foot and adapt as necessary. But I think the draft before you is a good draft. Hopefully it's a good starting point anyway, but I'm very happy to take any questions and have it tested, stress tested. Thank you.
Great, thank you, David. So I'll, with that, open up to questions to committee. And Claire first.
Thank you very much. And yeah, it's a helpful paper. Just looking at the diagram that you've got with the on the ICS strategies and plans, and it describes place and system, but people are missing. I just wondered if there was a particular reason for that, or whether you feel it's incorporated sufficiently in the others.
Yeah, I think that was setting out the formal responsibilities of the boards to each other. Within Wiltshire, you've obviously got your primary care networks at what they call neighbourhood level. So, and that the aims and ambitions around that are captured under the Connecting with Communities localisation scheme. I think integration of services as well can happen at a number of different levels. You can plan them at system and place level, but there are commitments in there in terms of the personalisation of services and those planning personal budgets and personal health budgets. That's where join up's got to happen around the person as well. So that should be covered off in there. There should be sufficient text to address that point.
Would it be okay to just quickly come back? I was thinking, yeah, I get what you're saying. I just wondered, that it's not explicitly put forward in that model. And also there's a very important piece around recruitment and staffing that none of this is going to happen unless we kind of address that across the system, not just in Wiltshire, but across the whole system. I just wondered if you had any thoughts on that. Thank you.
Yeah, workforce strategies is, again, that's covered under the integration and working together. So under theme 4, there's a commitment there to both enable frontline staff to work more closely together, but also to plan workforce needs together. This is something which is actually addressed in the integrated care strategy as well, but you have to do some elements of that locally. It can't all be done at system level. And there's a number of other enablers for workforce, such as joint IT records and actually co-location where that makes sense to do so. But this isn't all going to happen overnight. It's going to be step by step that we get to where we need to on that.
Thank you. Any further questions? David.
Yeah, this is interesting set of objectives and yeah, it seems all the right groundwork. So thank you. Just something that's just cropped into my mind, really looking at the preventative, is I've several times noticed a preventative work being done in partnership with private sector, with education, with other entities across society. And I know particularly pharmaceutical companies have put money into preventative programs on things like cardiovascular and COPD. Is there any provision in the strategy for thinking about working with partners beyond the council and NHS framework into private sector and other organisations?
Yeah, I think, well, Kate might actually be better placed to answer this one, but there is public health activity in terms of outreach to some of the major employers in the county, and that's something that the Health and Wellbeing Board has looked at before. The particular commitment in the strategy, though, is to target outreach activity where we think there are particular inequalities and where it makes sense to do so. So I think the officer groups that we have will have a role in identifying which groups should be targeted for that. So, but that could involve, I mean, say construction, for example. There's higher levels of smoking and in construction, so it could involve that sort of thing. But we don't tie ourselves down in this because, as the discussion was a minute ago, the data may change, and therefore we need to make sure we adapt to that as it does change.
Any further questions? Gordon?
Sorry. David, a very comprehensive plan. Personally, don't see any reason why this shouldn't go out to consultation, which I think what we've been asking. But what I'm more interested in, that once consultation is completed, I guess there will be an implementation plan put together.
I think the implementation plan will be the Integrated Care Alliance's work programme. That's how this will be delivered, through the work programme of the Wiltshire Integrated Care Alliance, as well as the influence it will have on the commissioning plans alongside the JSNA. Does that answer your...
Key performance indicators, I should think.
Sorry, Gordon, I'm struggling to hear.
I said, and in key performance indicators against...
KPIs. In terms of the monitoring performance of this, there'll be progress reports against the commitments in the strategy, but the real performance monitoring has to be done through the JSNA, because that's the outcomes level. Those are the outcomes we're trying to change, and they're measured and recorded in the JSNA. There's a wealth of indicators that the ICB and the and the council are talking through in terms of measuring things like discharge activity. But that's a level of data which I think is too detailed for inclusion in this, but say if you think differently.
Thank you very much, David.
Sorry, I just wanted to ensure we've got a form of words in our resolution to capture sort of forward monitoring. Were there any further questions from the committee? No. Okay, in which case I'll move a resolution that we note the draft health and wellbeing strategy for consultation, that we will seek some regular updates on how it's performing against the ICB's implementation plan, and obviously we'll be able to monitor KPIs through the JSNA, and to receive a progress report 12 months after publication to review progress against the objectives of the strategy, if you'd be willing to do so.
Yeah, great.
Thanks, David.
Thank you,
Could I
Chairman.
then have a seconder for that? Yeah. Thank you, Gordon. Any objections? None? Great. Thanks very much then, David, for that update. Very helpful. And we shall move on to item number 8 on the agenda, which again sort of ties in with what we've heard previously, and this is the integrated care strategy for Bath and North East Somerset, Swindon and Wiltshire. So the system element, I guess, if you like. So in January, the committee received an update on the plans for an integrated care strategy for Baines, Swindon and Wiltshire. The strategy is now in its draft form and is being presented for the committee's scrutiny and feedback. So to introduce the report, we're joined by William Pett, Associate Director of Policy and Strategy at the Integrated Care Board, and Fiona Slippen-Brown is also here as well to provide input. So I'll hand over to you both, first of all, for the presentation, and then we will open up to questions. Thank you.
Thank you, Chair. So I'm just here to open up this item, and Will go through the detail of the presentation, but I thought it was important to sort of set the scene, particularly in the context of the last two presentations that we've had, because hopefully colleagues will be starting to see that there's a kind of a theme as we run through from the JSNA, the health and wellbeing strategy, and the ICP strategy development, and we should start to see, as Will talk through, those themes around the needs of local populations, local communities, and how we're going to help support our population going forward, being coming through on this in the strategy at the ICP level, as well as obviously at a local place level. And we came here back in January, as you've mentioned, Chair, with Richard Smell, who's the executive lead on this particular piece of work. And it's important that as part of the engagement with colleagues around the final version of the strategy that we're coming back to get any further thoughts or comments that you might have. And you should have seen the draft because it would have come out with the papers previously. And I'll hand over to Will now.
Yeah, thank you very much and good morning. I'd like to, over the course of maybe about kind of 10 to 15 minutes, give you a bit of an update on where we've got to with the integrated care strategy since January. The document has moved on quite significantly. We've now got a new structure to the document, a new vision for it. We'd like to test that vision, that structure with you today. I think, I don't know, a quick question. Have members of this committee seen the full draft? I'm taking through some slides that explain where we've got to. You have seen the full draft? Yes, fantastic, brilliant. Okay, so in that case, what I'll do today then is give you some context to the strategy. David and other speakers have covered a bit of this, so I won't dwell too long on that. What I'd really like to spend more time on is explaining the strategy vision and indeed the strategic objectives that sit beneath that vision. And then also kind of raise with you this idea of a leftward shift of funding to support prevention that we are considering including in the strategy, which we'd like to test views on today. Hopefully also we'll leave you with some clarity on what's next for the strategy and how we will get to publication by the end of March. So next slide, please. So there's a number of graphics in this presentation that are pretty horrific, and this is one, and I'll apologise for this as I'll apologise for some others. But really this is just to say that we unfortunately have a complex landscape of strategies and plans across BSW, and part of that is a necessity of the new legislative framework that we have. But you can see on the right that there's a plethora of plans and strategies. These cover some that sit within the NHS. There's plenty of others that sit across local authorities as well. Really what I want to emphasise is that the goal of the integrated care strategy is to provide some clarity to residents about what they can expect if they are a resident of BSW over the next 5 years, whether they sit in any of the three places, and what the system, the integrated care system, will be doing to enable each place to achieve those ambitions for residents. So I won't dwell too much on this. Really, I just want to focus on perhaps the last point on this slide, which is that the integrated care strategy has no legal enforcement mechanism. No individual organisation is going to be hauled over the coals in 5 years and asked why they haven't delivered X and they haven't delivered Y. This really is the essence of integrated care systems and about health and care services working together. This is not about making any organisation within the system do anything or act in any way. It only has effectiveness as a strategy if there is partner support and if there is buy-in across the system for health and care services to work together, and indeed the third sector as well, to work together to achieve some shared ambitions. So really, that I want to kind of emphasise that today, is that this whole strategy depends on the buy-in across the system, and really we'd like to have your buy-in over the next few weeks and from publication onwards. So next slide, please. David's covered this slide already in his presentation, so I don't want to repeat what's already been said. But really this just shows the relationship between system-level strategies and indeed place-level strategies, including those that you've already heard about from the previous speakers. So what we've tried to do as far as possible with the integrated care strategy is build on that engagement work that's happened within Wiltshire and indeed the other two places, rather than replicate it and make sure that it's reflected in a system-level strategy. So the next slide, please. Final kind of piece of context really around the background to integrated care strategies. These are the kind of purposes of integrated care strategies. And really, I'd kind of like to focus perhaps on two here. The second one is that it needs to engage people, communities, and organisations. And we've really tried to make sure this has been a bottom-up process rather than BSW as a system trying to dictate, well, this is what we're going to achieve and everyone has to follow suit. We've really tried to make it as collaborative as possible. The third point as well is that really the strategy should be addressing the big complex issues that require a system response rather than a place response, which has been covered in your health and wellbeing strategy. So, a couple of issues have been mentioned already today. Workforce is one issue where actually it really makes sense for us to be looking across the system about how we can retain the best workforce that we can, make sure there's good working practices and culture across each organisation. And another one is kind of electronic patient records. Working as a system really makes sense in that area, and that's where the system can add value, and so that's reflected in our strategy. The next slide, please. I won't go through all of these, but really this is just to set out some of the principles that we've applied as we've tried to write the strategy. Just to pick on a couple, the second one is about it being accessible. So this is not an NHS document, this is not a local government document, it's not for those that are delivering services, it's for those that are receiving them as well. It's for any resident to pick up, to be able to read through, understand what the system is delivering for them over the next 5 years. And for that reason, it needs to be understandable. If it's not understandable, if it's not written in plain English, absolutely tell us, because we need to make sure that anybody can pick this up and understand it. The third one is about it being commitment orientated. So we want to commit partners across the system, not necessarily just to some kind of outcomes and ambitions, but also some behaviours and cultures. And we really think this could make the document a really valuable one for the next 5 years in terms of partners holding each other to account on how they should be acting and how they should be integrating together. And then a final one I'll just pick on this slide is around it being broad, so the fourth point. This is not about taking action on everything. There's going to be plenty of issues that are not covered in this strategy, and rightly so, because they'll be picked up by each of the 3 places. This is about ensuring that we set out a broad direction of travel for partners over the next 5 years. So something to bear in mind as part of your kind of feedback and comments. Next slide, please. I want to address head-on some of the real challenges that we faced with producing this document, and I don't want to shy away from them. It's useful, I think, for members of this committee to be aware of them. So I've said that, really we want the strategy to be driven by community and resident engagement. So for that reason, what we tried to do is build on the place documents. We've had some engagement events, but really we've been working since the end of October. So it's been a really short turnaround for this document. We've tried to do as much as we can with the VCSE alliances across each of the places. That's included engaging with Local Health Watch. And really important point is that we want to position the publication of this strategy as very much the beginning and not the end of an engagement journey with communities across the system. We will have opportunities to refresh this document every year, and really it should be considered a live document, not something that's final. I'll quickly just take you through the second challenge as well, that really, this, as I've mentioned, this needs to be co-owned, it needs to be developed with partners. And so what we try to do is take versions of this strategy to partners on an iterative basis, rather than kind of do a ta-da, here's the final version. This, what I'm taking you through today, is the next iteration. It's not the final version. So we are still very much in listening mode. However, we do need to have publication by the end of March. So we are in listening mode, but not for much longer. We really need to make sure this doesn't feel too NHS based. So just a quick point that we will be engaging with each of the 3 Directors of Public Health over the next few weeks and making sure that this document feels as much local government as it does NHS. And we appreciate we have some way to go on that particular point. So next slide, please. And I'll now take you through some of the detail of the strategy, having provided some context. Next slide. This summarises where we have got to with each of the 3 places and their health and wellbeing strategies. So you've heard this morning about the Wiltshire Health and Wellbeing Strategy, and just to kind of note the 4 kind of key objectives within that of improving social mobility and tackling inequalities, prevention and early intervention, localisation and connecting with communities, and integration and working together. Now, the challenge with this document is that we need to come up with a strategy that pulls together each of the 3 places objectives. So that's what we've tried to do. And next slide, please. So this is our first approach. Sorry that the wording on this slide is quite small, but really what it reflects, and as I said, we've moved on since this approach. But the first approach that hopefully you will have seen back in January was we had a structure of the 5 kind of life cycles: starting well, living well, aging well, dying well, and then whole life outcomes. Now, this felt fairly NHS-y. I think this is quite an NHS way of looking at the life cycle, and so we've taken on board feedback. We started with a vision of working effectively together to improve health and well-being and reduce inequalities across our population through a focus on prevention. Now, that's a bit of a mouthful, so we've taken on feedback on that front as well. So could I go 2 slides forward, please, because I won't dwell on the next one. And 1 forward again, please. Oh, 1 back. Perfect, thank you very much. So this is our new approach, and this is what is now reflected in the working version of the strategy that you can see. So we've shortened the vision. So the vision for partners across BSW now, and again, drawing on those 3 health and wellbeing strategies, is working and listening effectively together to improve health and wellbeing. Our engagement with the VCSE sector has really emphasised that listening component is key. We need to be constantly listening to communities and making sure that their needs are reflected in this strategy, and so we've really tried to embed that in the vision. So now you can see that rather than a life cycle approach, we've picked out 3 strategic objectives, trying to make it as simple as possible, that will deliver against that vision for residents. So the first one is focus on prevention and early intervention. The second is fairer health outcomes, and that includes reducing health inequalities. And thirdly, excellent health and care services. That's what any resident across the system should expect. You can see in terms of how we will deliver it, we want to build on the engagement that's already happened through the BSW care model. That includes things like personalised care, making sure that there's kind of joined up integration in terms of the way that care is delivered within communities. And you can see along the bottom as well the enablers that we have around workforce, technology and data, estates, etc. These are the issues that as a system we feel we can really add value to the ambitions that places are trying to achieve. Next slide, please. And really this is just to emphasise that other systems are in the same process of producing strategies, and this is a similar approach that's being taken by North East and North Cumbria. So just to reassure that the approach that we've proposed has some precedent in other areas of the country where they have multiple local authorities. Next slide, please. And this is the final kind of substantive slide in terms of content, but at the moment we're exploring how we can include an ambition within the strategy around refocusing funding and resources to deliver prevention. So again, I won't dwell on this too much, and you won't be able to see perhaps some of the text on this slide. But in the top right-hand corner, you can broadly see where we are at the moment, and you can see that there's a large chunk of funding and resources in hospital, less so in community care, and even less so in self-care. We would like to include an ambition in the strategy to start to rebalance that kind of allocation of funding and resources over time, so that there is a higher emphasis on self-care and community care, which ultimately, again in time, should mean less needed for hospital care, which is of course not where we want residents to be, and it's also much more financially expensive for us to treat people in that setting. So the idea of this leftward shift ultimately would be to achieve what we call the triple aim. So better health and well-being, better quality of care, and better financial sustainability in the long term. Next slide, please. So just to provide some clarity on next steps before I open the floor to questions and comments. We need to have this strategy published. This is a statutory requirement to have the strategy published. We want to have it published by the end of March. Obviously leaves us not huge amounts of time. We've shared the current draft with ICP members, and we will be receiving verbal feedback this afternoon, and indeed written feedback until the end of this week. We want to present a final version to the partnership by kind of mid to late March. And as I've mentioned, this is not the end of the engagement. We have more sessions planned with the VCSE alliances across the system over the next couple of weeks, as well as with the DPHs, as I've mentioned. The engagement will continue after we've published, but that's what we have planned for the next couple of weeks. There are some associated documents I won't talk too much about. The main one is the Integrated Care Implementation Plan, and that will set out more of the how we will deliver it. So really, this is the strategy of what we want to do. The implementation plan will set out the how, and that will include the 3 different place-based approaches as well. Final slide, please. So, of course, I welcome any comments, any general questions, but also particularly your feedback on some of the questions there would be very welcome. So what's your initial thoughts of the vision that's been proposed for the strategy? And do you believe that in terms of those strategic objectives, the 3 that I've outlined, are they the right ones? Should they be tweaked in some way? And then a third question around, I've outlined the kind of case for the refocusing funding and resources to deliver prevention. Are you happy for us to include that as an ambition within the strategy? And I'll leave it there, Chair. Thank you very much.
Thank you, Will. That was a really good and clear presentation. I hope members found that useful, and very much welcome the opportunity to have sight of this before the final version is published. Any questions from committee members? Pip.
Just an observation. You say it in plain English. If this is going out to your average person in the public as opposed to round this table, there are a lot of words there that will not be understood. I think you need to actually, if it's going out to the public and to voluntary groups who have residents, I do think you ought to clarify a bit better what some of the longer words mean, because it's all right for us, but the public will just take one look at, some of the public will take one look and just say, what's that mean? What are you trying to do? And I think when you go out to the public in general, then a simpler form of some of the questions would be appreciated. Thank you.
I think that's a really fair challenge. And I think just to further explain how we want to publish the strategy, the full strategy is going to be probably, unfortunately, a kind of between 40 and 50 page document. Now, a resident doesn't have time to sit and read through a 40 or 50 page document. So what we plan to do alongside the full version is publish a one-page summary so that any understand what we're trying to achieve over the next 5 years. And secondly, an executive summary version that maybe gives a bit more of the detail, but is over kind of between 5 and 10 pages rather than between 40 and 50. So we are trying to do what we can on that front, but it's a fair challenge, and we will continue to kind of value that.
Thank you. Thanks, Will. Thanks, Pip. Any further questions, David?
Hi, thank you. Really very interesting to see this progress. Just a couple of things, just on the communications. I just noticed while you were talking, I just looked up that there is a Facebook page I see for NHS BSW, as it were. And will you use that to communicate with the public and try and get ideas? Because I mean, I agree with Pip that you need to communicate simply with the public, and even a one-pager may not get to them. Whereas with social media, you can get to a lot of people, and you can ask very direct one-off questions like, what should we do to prevent more illnesses? To do left shifts, in simple terms. And you might get some interesting responses. And on that same thought, I mean, will this be, not necessarily before it's published, but will it be communicated to other organisations in the public who may also better make contributions? Again, private sector companies, but I'm also thinking of, for example, sports teams, of whom we have masses across Wiltshire. If they were asked, what are you doing to help support health and well-being, for example, both physical health preventative and mental well-being, they would probably come up with maybe some answers that we wouldn't have thought of. I'm thinking about, for example, the things they do for older people through walking football or whatever might be come into it, as well as stuff for young people. And finally, 2 things. The implementation plan and the operating plan, do we get to see those on this committee at any point? It was just because obviously it's nice to see the strategy, but it's also good to see the nuts and bolts of what's actually planned to happen.
We can incorporate that to a resolution, absolutely.
Yeah, it would be good to see the thing. And absolutely finally, working and listening together just gave me the thought that maybe they're two separate things. And I thought if you work together well, you would listen. So maybe it could just be working together or even just collaborating. But that was just an editorial thought to take on leave. Thank you very much. Anyway, great presentation.
Thank you. So, point taken on the last point, and let me just briefly respond to your other three. So, thank you very much for the suggestions. The one about social media is absolutely a valid one. Yes is the answer. We will be using social media channels to publicise this as widely as possible. Part of our kind of trying to make this as clear and accessible as possible is perhaps kind of video content. We'd really like to have members from across the system explaining our vision a little bit more so that it's not just residents having to read documents. So that's definitely something that we'll be exploring and using. So thank you for the suggestion. Other organisations, absolutely. So there are plenty of sectors that we haven't had a chance to engage with, and we've been clear about that. So the police, for example, we'd love to get the police involved in some of the ambitions in this strategy. We haven't really had the opportunity to do so yet. So the mechanism for that is the Integrated Care Partnership. So the Integrated Care Partnership within BSW brings, and in theory should be bringing together all parts of civil society, all parts of the public sector to be talking about these big complex challenges that involve not just health, not just local government, but as you say, police, housing, etc. So we've had the first ICP meeting and the only so far ICP meeting back at the end of October. So we're still very early in our infancy, but absolutely the plan would be that that partnership would grow and evolve and start to incorporate those partners that you talk about. So yes, thank you for that. Final point that you made was around the implementation plan. Yes, as far as I'm aware, that plan can be brought to this group. Just to highlight that the implementation plan has had to be, by necessity, a bit further down the line, given that it's to deliver this strategy. So that is coming by, I believe, the end of May. And yes, I can absolutely make a note for my colleagues to come and present that to you.
Thank you, Will. Claire, and then Gordon.
Thank you very much, and thanks. That was a very interesting and helpful presentation. I should mention I do work for the NHS, have done all my life. I work for NHS England in what was NHS Digital, so not locally. Couple of things. I agree with what Pip said about language. I had no idea what the subsidiarity piece meant, so that would be a good one to clarify. And in terms of the sort of journey from the life cycle approach, which I kind of related to with my NHS background and what you're moving on to, I wonder if there's an opportunity to sort of map the two together a little bit. That might be good. And also looking at those three topics, you had prevention and early intervention, fairer health outcomes, an excellent health and care system. Now, I think the excellent health and care system is what delivers the other two. And I wonder if there's a way of explaining or portraying that is meaningful. And the third point I wanted to make was I think we've been trying to do this shift to the left, if you like, for a long time. We know that it's better to do the care closer to home or prevention, all of that. However, we are still in a place where people get sick and require hospital treatment. How are we going to get past that bit where we're spending all our money on acute care, knowing that we want to spend more of our money in more on the left of that continuum, if you like? Because I think, like I say, we've been kind of trying to do that for so long. How's that going to happen? Yeah, I think there's the points I wanted to get across. Thank you very much.
So let me take each of those in turn, and thank you very much. So firstly, on the life cycle approach, we're not, as I like to reassure, we're not abandoning the life cycle approach completely in the document. We are going to be using the life cycle approach, not least to present some I statements that residents should be able to say after 5 years in terms of the standard of care they should be receiving, whether from third sector, health services, care services, etc. So we will be using the life cycle approach and haven't abandoned it completely. Second, on your point around kind of the strategic objective of excellent health and care services, you are right to some extent that that is a mechanism for delivering the other two. It's a useful objective for us to have because within that we can hang lots of other elements. So, for example, where we talk about our emerging mental health ambitions and our mental health strategy, yes, that does fit into inequalities to some extent, but there's plenty of material that we really want to include in terms of just the quality of services that people should expect. We will take that on board, though. Let me think a little bit more about that. So thank you for flagging it. And then just finally on prevention, you're absolutely right that prevention is not a new concept. We've been around the houses on prevention for decades, and what's going to make this any different is a very valid question. I think that's a very complex question that really needs a complex answer, and I'll try and give you a simple one, which is that for the first time, we have a legal structure through integrated care systems that actually brings together health and care services and indeed wider partners. We've tried to make prevention work in the past through a system that's been based largely on fragmentation of services, competition between providers, and that's partly, in my opinion, I'm speaking slightly off the record here in terms of my personal view, that's been the fundamental barrier to any meaningful progress on prevention for the last kind of 15 to 20 years. I think that there's a lot of enthusiasm for integrated care systems as being the model through which we can finally start to get multiple partners around the table. And to what you're talking about, really in terms of prevention and stopping people ending up in acute care, we're talking about the wider determinants. We're talking about people's housing. We're talking about the environment that people live in, whether they have access to green space, whether they're active as part of a sports or leisure club. These are the things that stop people getting to the point where they need acute care. Only by having multiple partners around the table can we address those. We now have the model to do that. So I perhaps naively have some enthusiasm for us to being able to deliver that over the next 5 to 10 years.
Thank you. Good questions and answers. I just wonder if we could come up with another term other than left shift. It makes me flinch every time I hear it. But anyway, perhaps that's just me. Yeah.
Valid point. Yeah, that's taken. Thank you.
Gordon.
Morning, Bill. Thank you very much for, again, a very comprehensive presentation. We've certainly given us a very good overview of the plan and strategy. I'm looking at slide 14, which we looked at the shift really in focus away from hospital toward self-care and community care, which I absolutely support. But communities every community is different, hugely different. And I just wondered, how are we going to ensure going forward that each community is sufficiently resourced and resilient enough to cater for those needs which you have outlined? Because some of them might not be.
Yeah. So I'm going to slightly duck that question actually, because I'm here on behalf of the Integrated Care Partnership, developing this document at kind of system level. What you're talking about is absolutely right, but what we don't want to start doing as a system is telling each of the 3 places how they should be responding to their own communities. That's not the purpose of an integrated care system. So what's developed within Wiltshire absolutely is with the domain of Fiona, Kate, David, and colleagues. It would be inappropriate of me to be telling Wiltshire how they should be responding to their own communities, and indeed that's not the purpose of the strategy. But your point is a valid one.
Yeah. Secondly, Chair, in your slide 3, you did remind us that the integrated care strategy has no legal enforcement.
Yeah.
But nevertheless, this is an overview and scrutiny committee, and our function is to make sure that scrutiny does take place. And so therefore, David's question about the implementation plan is valid, and we would like to see that. And maybe to meet with you again in 12 or 14 months to see what progress is being made against the strategy. So, we work to government's guidelines on health scrutiny as well. And it is necessary to make sure that benefits are accrued. So, can we see you again in 12 or 14 months' time?
Absolutely, you're absolutely right. So I think the kind of short-term measure of success for the strategy is are the ambitions and is the vision of the integrated care strategy reflected in the health and wellbeing strategies? Is there clear alignment? Does it make sense? Does that complex landscape of strategies that I talked about at the beginning, does it make sense and is it aligned? So I think that's the short-term kind of barometer. Longer term, absolutely, we need to make sure part of the design principle of this document is that it's measurable. So we need to have some mechanisms to make sure that after 1 year, 2 years, 3 years, we have some way of determining whether or not we're being successful or not. And absolutely the job of the Integrated Care Partnership is to make sure across the system that we are delivering against the ambitions that we set. Very happy to come back in 12 months' time, 14 months' time and present kind of where we've got to back to this committee. And yes, you're absolutely right.
We look forward to that.
Great, thank you. Further questions, Howard?
Thank you, Chair. I just want to come back on Gordon's point, if I may, which is actually a very powerful one. We've just been through the budget setting process, and you'll be aware that there's some somewhat mixed fortunes across BSW, and so I can see there being considerable disparity in the provision of this across the piece, and I can see you being involved implicitly, if not explicitly, in the fact there will be some disparity potentially, because there are big differences, dare I say, between resource provision and budgetary provision potentially throughout us, between us and neighbouring authorities. And I do think it would impact on this. And you gave us your last talking point. I think you put up 3 questions there, and the last one was to do with funding and resource. And were we happy to support that? Well, of course, we are happy to support that. But I think I have to give the heads up that you may run into problems or you may foresee difficulties with the provision not being there in a uniform sense because of budgetary disparities across the piece.
So I think that's a point that's very well made. I'm afraid that decision around funding is way above my pay grade, but I will have to note that comment. And yes, that's something that absolutely I agree with, and something we'll have to pay attention to as a system.
Good, thank you, Howard. And Mike?
Thank you, Chair. I want to touch on a similar point, but I think with the best will in the world, this is one that might be ducked as well. And it's prompted by the refocusing funding and resources to deliver prevention. And it's to increase the amount of money spent on community care. And I think one of the obvious questions that members of the public might ask is, well, does that mean we'd be looking to reopen community hospitals where we still have them? Because we all know that one of the big issues at the moment is bed blocking in the major hospitals. And we already know that we're buying beds within care homes to try and mitigate that. So, as I said, I think one of the obvious questions would be, in response to this, would we be looking to make use of community hospitals where they still exist? For example, Melksham.
So yes, I'll do what I can to answer that. I think part of that, and Fiona may be able to come in on this question. I think, to my mind, part of the strategy is really emphasising care as close to people's homes as possible. So even talking about kind of community hospitals, yes, that might be the right and most appropriate setting for some residents. It won't be right for all. And really what we want to try and do is have kind of really comprehensive and robust step-down care from hospital, rehabilitation services, and as I say, care as close to people's homes as possible. Now, there's various ways we can do that, but that's what we've set out within the strategy. Whether that involves community hospital, I'm afraid I don't know. Fiona, I don't know if you want to come in on that.
Yeah, thank you, Chair. Very happy to come in on that. And I think a couple of things, and Will mentioned it in his slides. One, about making sure that we get the model of care right, so we're really clear what we need to do together to achieve those outcomes for our populations and our estates, and I mean our estates, because we're talking about kind of one public estate, our estates being an enabler to the delivery of that model, and they may include the current estates, but it might be that we need to look to build different types of estate provision or refurbish some of the estates that we've already got. Much of, certainly from an NHS point of view, the estates that sit within the NHS is not fit for purpose. It's not certainly fit for the 21st century level of provision. But that is something we'll have to address together over time. And I know we've already started to have some conversations with council colleagues around some opportunities in that space, but absolutely we'll need to look at that, particularly in the context of care closer to populations, how we want to develop our primary care networks, because many of our primary care premises, again, you know, are not in estates that would allow for expansion of delivery or an extension of an out-of-hospital offer or community-based provision. So we'll absolutely have to look at that in the round. But in terms of what we need in terms of bedded care, yes, we've got community hospital beds in Wiltshire, but Emma's going to be talking later, I think, around market management, and more we are looking to collaborate and jointly commission hospital provision or bedded provision outside of hospital settings together with council colleagues, and we'll continue to do that.
Thanks, Fiona. Thank you for that. Any further questions? Gordon, another.
I do remember it was announced about in the last year that there were plans to build a diagnostic centre in Peasdown St John. Is that still on the cards? Is it still going forward?
I think it's probably worth, Chair, us bringing something back separately around community diagnostic hubs, because I think that in itself is kind of a slightly separate item, but maybe worth covering in terms of wider access to diagnostics and elective care recovery. That might be something we want to consider bringing here as a separate item.
It's something we could cover in the further work programme, because there was also the discussion we had about integrated care centres, which relates to Mike's question as well. So I think there's probably an agenda item there to look at sort of those estates type. Yeah. Thank you. Any further questions from the committee? No? Okay, well, Fiona Will, thank you very much for that. I will move that we note the draft BSW integrated care strategy, request the implementation plan once that's finalised, and to receive annual updates to follow progress. Could I have a second? Yes, so to receive annual updates to follow progress, including sort of an initial update in 14 months' time. That could take the form of maybe a task group, or we could bring it to committee. We can decide that between us. Could I have a seconder for that? Yeah, thank you. And any objections? None. Great, that is moved. So we move on then to item number 9 on the agenda, which is a hearing and vision service update. As part of understanding the range of health and adult care services provided by the Council for Wiltshire residents, we've requested an update on the work of the Hearing and Vision team. Here to present the update is Emma Townsend, Head of Hearing and Vision Services, and Emma Legg and Jane Davies are also here as well to input. So we'll hand over to you for the presentation, and then we'll open up the committee for questions. Thank you.
Part of our prevention and early intervention strategy. Relatively small numbers of people under 64 have visual or hearing impairments, but it's something that rapidly accelerates as people age, and we're very committed to ensuring those people maintain or regain independence and confidence. Emma is here, but our other Emma is Head of Service for Living Well, and I believe she's going to give us the detail. Perhaps Emma's going to speak too.
Thank you. Thanks everyone for inviting me here today to share some of the work that the Hearing and Vision team do. I'm asked specifically to focus on the support we offer to people with vision loss. But I'm going to touch on some other aspects of the team as well, just to give you an overview, and I'm more than happy to come back and give a bit more detail on some of the other areas of work that the team do. Could you move to the next? So to start with, I'm just sharing here some data around the prevalence of visual impairment across Wiltshire. So the numbers above at the top of the chart are taken from the Institute of IPC at Oxford Brookes University. So I've just suddenly forgotten what IPC stands for. It shows the prevalence of sort of serious, moderate or severe visual impairment that we should be seeing across Wiltshire in terms of our demographics and our population. So 2025, we should be sort of supporting around 11 or 12,000 people with that level of visual impairment in Wiltshire. They've summarised the most common cause of registrable sight loss in older people is age-related macular degeneration. So that's the prevalent sort of condition that people have. We hold sight registers in Wiltshire, and I'm going to talk a little bit more about those a bit later on in the presentation. So on our sight registers, we probably know about half of that number of people. So it's potentially a lot of people living in Wiltshire with sort of moderate or severe visual impairments that aren't known to us as a service at the moment. Next slide, please. As Jane mentioned it, we have a small team, but we have a range of different specialists within the team, and they support people with hearing loss. And we have a specialist social worker specifically working with our deaf community. And we also support people with dual sensory loss, so people who have both a hearing and a visual loss, and specialist workers looking at that impact of that double sort of impairment that people experience. And then we have workers working with people with visual loss, which I'm going to talk a little bit more in detail about a bit later on. But next slide, please. I'll just talk a little bit about the other aspects of the team first. So our dual sensory work, we have 6 staff working in this field. So again, not a huge number of staff, but they're very specialist staff with skills around, with a range of communication skills and assessment skills to support this small population across Wiltshire. We work within the Care Act. The Care Act gives us specific duties around working with people with dual sensory loss. It describes the type of assessment that they should have, the type of skills that assessors should have, and training, what we need to consider as part of that assessment, and what care and support we should be looking to put in place to meet the needs of those individuals. Within the team, as well as our dual sensory specialists, we have staff called communicator guides, and they are the people that work alongside those individuals on a weekly or a daily basis sometimes, really helping them to access sort of society really. So whether that's about reading, going to the bank, going shopping, all those sort of daily living activities that people who have a dual sensory loss find a real challenge. So our communicator guides work alongside them and support them with those activities. Next slide, please. So we have other members of the team working specifically with people with hearing loss. We call those rehabilitation officers who work with hearing impaired people. And they focus a lot on very preventative and early help. So they get referrals from audiology departments typically, and they'll provide specialist equipment, they'll provide advice, guidance, support, and people can self-refer as well. So once people are further along that journey, they can refer in for additional help, equipment, things that they're struggling with. And then we also have, as I mentioned, a specialist social worker who works with people who are deaf. So these are typically people who with British Sign Language as a first language, and she undertakes as well as supporting kind of regular coffee drop-ins for that community, come and meet and share with her and with the team some of the struggles they're having and some of the needs that they have. She also undertakes our sort of statutory duties, so that could be around safeguarding, or it could be around community care assessments. So a range of duties and support that she provides that quite small community. Okay, next slide, please. So moving on to a bit more detail about the support we provide people with visual loss. So we have 2 key functions in the team. One of which is about holding sight registers. So this slide describes some of that work. We do have a statutory duty under the Care Act to hold sight registers for people. Typically, the start of the process is through a referral and a certificate from our ophthalmology department. So we work really closely with our health colleagues in those departments, with our low vision clinics, with eye care liaison officers. We make contact then, and there is a timescale within the Care Act that says that we need to make contact with those individuals within 2 weeks to have a conversation about registration, to offer them an assessment of their needs. And that assessment's done by a rehab officer for people with visual impairments. The team also hold the register for children's visual impairments as well. So they hold the whole range of registers for the organisation. Next slide, please. We have ROVIs in our team, so rehab officers for visually impaired people. So once someone identifies that they would like an assessment, then that's undertaken by a trained member of staff called a ROVI. So they're qualified and trained to support people to regain or maintain daily living skills alongside their visual loss. And that might be about learning how to do things differently. It might be about using particular equipment within the home to help them navigate or help them to undertake tasks more safely. They also undertake quite a lot of mobility training outside the home, so working with people to learn different routes to places they might want to go regularly, shops or work, to make use of sort of equipment like long canes, and find the most appropriate type of equipment and learn to use that safely and confidently. So it's a lot about independent skills, it's a lot about confidence, it's a lot about making sure people can continue to live their lives. The Care Act does describe the ROVI role as not as a statutory duty as such, but as an example of how, as an organisation, we can meet our prevention duty. Care Act gives us a duty to provide preventative services and support, and this is a really good way, good practice way of us doing that. There are only about 500 ROVIs in the country, so they're really, really hard to recruit to. Once we lose a ROVI, so we are at the moment looking at making use of a new apprenticeship scheme and growing our own ROVIs. We have lost one recently, and that's how we're intending to fill the gap. We're also part of the Rehabilitation Workers Professional Network. They're just changing the name of the ROVI role to be called Vision Rehabilitation Workers. Next slide, please. So here's some data around some of our demand and our performance. So we only have, as I mentioned, a small team, 3.65 staff. And over the last couple of years, alongside COVID, 2 of those staff have taken maternity leave. And given the very few ROVIs in the country, it's been difficult for us to get backfill for those staff. So you can see that our waiting list was hovered around the sort of 150 mark for many, many months. And we also had a number of people on our waiting list who actually during COVID didn't want to progress with their referral, but we held on to them. And that was primarily because they needed some mobility training, but they weren't actually going out and about and were choosing more to stay at home, weren't wanting to access sort of community services at that time. So in September, you can see that we were fully staffed. Finally, staff came back from their maternity leave, and we started allocating more work, and our waiting list started coming down. And that's we're hoping that's going to be the trend for the next year. We have just lost one of those members of staff in December. You can see that December data's taken a bit of an impact, and that's what we're investigating the apprenticeship route for in order to replace her. Next slide, please. I've just shared here a couple of case studies for interest, just to give an example of the impact that the roles can have. The first one is a sort of middle-aged woman who his relationship's broken down. So she's relearning really how to live independently and parent independently with her sight loss. So the Rover's been really critical in supporting her with, particularly with her confidence around managing households, managing all her parenting tasks, and starting to think about actually going out and about. And the second example is a transitions case. So a young woman who's come through from children's services and moving into an adult life and starting to want to become more independent and explore what opportunities she now has as an adult. So again, real focus on helping her independence, her daily living skills, a big focus for her on getting out and about and her mobility training. Thank you. Next slide. So just to summarise some of our development areas, as I've mentioned, we are working hard on addressing our waiting list. So looking at a lead Rovi role, looking at apprenticeships to fill vacancies, and just giving those sort of quite small numbers of staff a bit more structure and support to manage their demand and volume. We work really closely with the fire service. They undertake safe and well visits, and they actually do give out some of our equipment rather than make referrals to us to go in and be a second person. They actually give out some of our equipment for us, and we work really closely to do that. Also working really closely with Wiltshire Site, which is probably one of our main sort of voluntary sector organisations in Wiltshire working in this field, and with children's services to make sure that transition process works well for those young people coming through into adulthood. Monitor our performance through our monthly performance outcomes group. And we are actually doing a bit of a review, just starting a bit of a review of the support we provide our deaf community and people with hearing loss, and whether we've got, looking at demand, whether we've got the right type of support, whether we're offering what people want, whether we're able to give them the right kinds of equipment, and whether our offer is really up to date or not. So just kicking that review off. So I'd be more than happy to come back and share the results of that at some point if that would be of interest. I think that's the end of my presentation. So any questions?
Thanks, Emma. I'll open that up to the committee for questions. Any, Claire's got a question?
Thank you for your presentation. You talked about the waiting list. Just wondered how long people wait to be seen and assessed and helped.
Yeah, so
Thank you.
Thank you. So it's a risk-based waiting list. So some people might get allocated quite quickly if there are particular risks and they're harming themselves because of maybe they haven't got the right equipment at home to be able to access this cooker, hot water, and they're burning themselves, or they're really at risk out in the community. So we have a risk-based waiting list. So it's not just chronological. So some people do wait a lot longer than other people. We do have people who probably have been waiting almost up to a year for some lower risk type of interventions.
Thank you.
Thank you. Pip.
Thank you. This is a statutory duty on local authorities under the Care Act, the Prevent and Enable. Who actually pays for it? Does it come out of the local Wiltshire budget, or do we claim it under the Care Act, or how does that work, Emma? Or, sorry.
Yeah, thanks, Pip. So yes, we absolutely have the duty to prevent, and I think within Wiltshire, it's actually a kind of key principle that we embed in many of our services and many of our teams. It can actually deliver financial benefits for the local authority, because obviously if we can prevent and delay the development of need, then we spend less on long-term care and support.
So no, we don't claim anything back specifically for that. It is part of our overall adult social care offer. But it does deliver obviously benefits for individuals, families, communities, and benefits for us as a local authority too. So it is an area that we want to develop in wherever we can, really.
Yes, Irene, and then Diane. Oh, sorry, no, I did have Gordon. Apologies, Gordon. No, Gordon, you were next, and then I'll come to Irene and then Diane.
Yeah, I've got a couple of questions. First of all, in my naivety, I didn't realise there was any difference in sign language. You mentioned British Sign Language. How different is it to anybody else's?
It's just the name of the language that a lot of people in the deaf community use, but we do have people who use a European Sign Language who've come across to UK. But yeah, I think there's American Sign Language. There's a range of different languages across the world. But British Sign Language is the one that we typically
certainly, I thought. Secondly, the national shortage of specially trained staff. Is the government aware of this, and are they doing anything about it? Or is there? Are we able to buy in support, and do we?
I don't know whether the government's aware of it or not. They have recently accredited a network to hold a register, because there's not actually a formal register at the moment of Rovies. But from March this year, there will be a formal accredited register. It's not going to be a statutory requirement for all Rovies to register, but there will be obviously benefits in terms of networking and training and support. And we're definitely would be encouraging all Rovies to register. That will give us a really, really good idea of where Rovies are and how many there are, and hopefully then make more business case to suggest there is more training on offer. There's very little training. There's probably only really two really good training opportunities for Rovies if they want to train to be a Rovie in the country. So yeah, it's a really niche type of role and training and development area that we should be able to support to grow through the new apprenticeship schemes.
The private market, is there a private market? Do we buy into it?
No, there's not really a private market that I'm aware of, though I do know that the third sector also employ Rovies. So the RNIB, for example, they do employ Rovies. So it's not just local authorities that would employ a Rovie.
Thank you very much.
Thank you. Irene.
I've got two questions. The first is, what sort of relationship do you have with SITE? It's a voluntary organisation. I know it provides support, local support groups, but do they are they commissioned in any way, or do you have expectations of them?
So they're not commissioned in any way. So it's just a relationship that we've built up in terms of working together. We make sure that we're not duplicating work. So we used to, for example, have a resource centre with a lot of equipment in for people with sight loss. Wiltshire Sight also developed a resource centre, so together we made a decision that we would close ours and we would be referring people, for example, to their resource centre. They provide a lot of sort of clubs and drop-ins and coffee mornings, so we work quite closely to make sure that we're encouraging people that we know to go along and get sort of that support from them as well. So we do work together in terms of not duplicating what each other's doing.
Thank you. And my other question was about the deaf community. And you talked about the services you provide directly. And this question based on my niece works in housing for another authority, and she provides a fortnightly or a monthly drop-in in sign language because she signs, and do provide and house it, and it's always full. And I don't know whether you provide that sort of service through other services, because housing is so important to people's health and well-being.
We do provide a drop-in services. So our social worker specifically is the one who organises and supports that. and she's a British Sign Language user. So it is specifically for people who use BSL as a first language. One of the points of us doing our review is that actually we know that the struggles that people who are deaf have isn't just about accessing social care services, but it's also about accessing health services, housing services, and other services. So one part of our review will be working with our deaf community to understand actually who would be better placed to be there, or who should we be also encouraging to attend those coffee mornings to help break down some of those barriers and have some of those conversations with them around access. Because I think for them, it's all about access to services and support.
Diane.
Thank you. I just wanted to go back, if I may, to your waiting list. And I know that you said that you might have some people waiting for up to a year. I'm just wondering, how do you monitor those? Because we all know once people are waiting, things can actually really deteriorate. And I wondered how you monitor those people on that list.
So we make regular calls to them, and then we would reprioritise. And if people are still not really ready to engage in some mobility training, for example, we would keep them on the waiting list, but we would probably give them a lower priority. So yeah, we stay in regular contact with people, and as things change, we encourage them to ring us as well if things change, and so we can be more proactive. But yeah, it's it's not where we would want to be, and we're hoping that actually with some additional staff through our apprenticeship route, then we'll be able to see that waiting list going down.
Thank you.
Can I, sorry, is that okay, just to add to that? I think just to pull out the point that Emma's made as well is that we recognise that people are ready at different points to engage with us. So other services may say, actually, if you're not ready to engage now, then we will take you off our waiting list, for instance, and can you come to us again in the future when things have changed? But we haven't done that because we think it's really important to maintain those strong links. So I think sometimes when you see the length of time people are waiting, obviously we do want to get to them as quickly as possible, and certainly work with people with the highest risk. But there are also people there who are kind of come into that in their own time too. So I kind of just wanted to draw that out as well.
There's on access. You mentioned breaking down barriers. When you did mention this access before, what work are you doing on those barriers?
So we're not doing any specific work with employers. We would be working with organisations that might support people into employment, and making sure that those organisations are accessible to people who are deaf, as well as people who have a range of other challenges and disabilities. Yeah.
Good. Okay. Thank you, David.
Yeah, thank you. Thank you for the presentation. Very interesting. And I thought that the case studies were interesting, and I've just been sort of mulling on the situations of those people. I just wondered about the personal assistant in the first case study. Obviously, you talked about the Rovies and the Rohies. I just wondered how prevalent are personal assistants, how much capacity and funding is there for personal assistants, and to what degree are we able to provide them or provide access to them in as much as they're required?
So we have a really strong working relationship with Mary and Wiltshire Sil. So Wiltshire Sil have as part of their contract, they support a personal assistant network and train and recruit and support people to recruit their own personal assistants and give advice around insurance and how to become an employer, and the responsibilities of becoming an employer. So it's a challenge, I think, and we're always advertising, and I think we're using Wiltshire Council website now as well to advertise some of those personal assistant opportunities. Yeah, it's a big part of our strategy in terms of our personalisation agenda across the whole of adult social care.
Does it tend to be sort of part-time, just a few hours a day or critical moments, or are they there for the whole day?
So what we would do is we would give someone a direct payment. So we would give someone the money to employ their own staff, and that direct payment would, the size of that direct payment would reflect the level of need. So that might just be about recruiting someone to employ someone for a few hours a week. But we do also have people who employ 2 or 3 full-time personal assistants to meet a range of needs across the week on a rota basis. Yeah.
Jane, did you want to come in on that point? Or was it a separate?
Kind of summing up points.
Okay, just 1 or 2 committee members with questions. Are you happy for me to go to those first, and then we'll come back? Councillor de Vendren.
Thank you for the comprehensive presentation. Basically, I'm just going to echo the question which the chair asked, which is what help is given for those who are visually impaired with finding employment, or perhaps starting a business, just to get them equipped and empowered? Will there be any steps taken in the future to look into that particular area?
At the moment, so we would be looking at, if as part of a Care Act assessment, potentially looking at whether people needed specific support to maintain or gain employment, but we would then be working with our employment support organisations. If it were the young people, it might be our West team, our Wiltshire Employment Support team, or it might be working with job centres, or it might be working with referring to access to work for that deaf person to get support in employment to maintain employment. So we have, for example, in the team 2 deaf members of staff who have funding from our Access to Work scheme for British Sign Language interpreters to undertake their work alongside them to help them communicate with customers and with staff and with partners. So that's a kind of support we would be looking to help people with. Okay.
Thank you. David, did you have a hand up? No, okay. Mike.
Could I just ask a quick question on the apprenticeships? Would there be any kind of learning agreement with the apprentice to provide some sort of tie-in? So as and when they got their qualification, they wouldn't just up sticks and go and work for a different local authority?
I'm not sure that we have a tie-in. We have a range of apprenticeship schemes across the council. I don't know the answer to that, but I don't think we have a tie-in, do we?
I think it's quite difficult to actually put that in place. I think how we offer it is that kind of training opportunity, and if people have been working for us for some time and obviously they potentially live in the area and are committed to continuing to work with Wiltshire Council, then we see it as part of our kind of options around career development, giving people those opportunities, so actually they've got a greater chance of staying with us than probably moving on to other roles or within other sectors. I mean, we have occupational therapy apprenticeships, social work apprenticeships, and a whole range across the council as a whole. There's always that risk, but we do actually find that our staff are really committed as a whole, and if we invest in them, then they do tend to stay with us, which is hugely positive. Yeah, absolutely.
Thanks. Can I just ask a quick question on prevention, just in terms of particularly hearing health? What sort of work is going on maybe with public health on encouraging better hearing health? I mean, we're all very good at having our eyes tested every year or 2. We're all very good at having our teeth done every 6 months to a year, but we're not so good at having our hearing checked, or indeed looking after our hearing in the workplace or, in loud environments. What sort of work's happening in that kind of area?
I know there's work going on in eye health area. There's an eye health working group which we work with public health in, and we promote good eye health and we make use of all the national campaigns. But I'm not so sure about hearing.
No, do you want me to? So probably the honest answer is nothing at the moment, because we have a very small public health team with a lot of priorities. That's not to say this isn't a priority, but just coming out of the pandemic at the moment, that's not something that we have capacity for anyone in the team to support in any great detail. There'll be lots of large national campaigns that we will be making sure we're using social media for, but obviously that's very different to having a very specific focus on that.
Sure. Yeah. Well, I mean, if there are national campaigns that the council can be sort of helping to raise awareness of, I suppose, that does cover part of it. And I guess then sort of slightly, I mentioned sort of hearing health and not having our ears tested quite as often as we have our eyes and teeth checked. Is there sufficient audiology capacity in Wiltshire for people to be able to have their hearing checked, on a fairly regular basis? Is that something we have knowledge of in terms of access to audiology?
I don't have any particular knowledge about that, about waiting lists or capacity or demands.
Irene's got it. Great, thanks. Jane, you wanted to sort of sum up?
Yes, I just wanted to say that we are ambitious for people with any kind of disability or additional need to be in employment. In Wiltshire, we exceed the national and the South West target figures for having people in employment. We think those figures are lamentably low. I can't remember them exactly, but it's less than 10%. And this is, we don't think that that's right, but we are exceeding national and our local neighbours' success rates in this area. So it is something we're focused on. Emma mentioned West, but we do work with other organisations too. And just to clarify about the waiting list, because it is a risk-based register, if you're assessed as high need, you wait days or week, perhaps a week or two, not a year. It's definitely about need and readiness to engage. Although we would like to do everyone sooner if we could.
Great, thank you. Were there any final questions on this item? Thank you. Oh, sorry, Claire.
Sorry, yeah, just going back to the hearing thing. I've noticed in the last week or so, there's been a bit of a campaign that there is a relationship between hearing loss and dementia. So it may be that that's something that we start elevating up the agenda. Thanks.
Yeah, absolutely. There's been a lot of publicity around that recently. I've also noticed that as well. Great. Well, thank you, all three of you, for the presentation and for taking our questions. I'll move that we note the content of the detailed presentation and receive the findings of the upcoming review on the Hearing and Vision Service. Can I have a second? Thank you, Howard. And any objections to that? None at all. And that's moved. And we shall move on. Thank you, Emma, for the presentation. To item number 10, Market Sustainability Plan for Wiltshire. Market sustainability plans are new to councils and were introduced by central government. This March will be the first time councils will be submitting the plans. We asked for a progress report on the plan and understand how this will impact on the provision of adult care services for Wiltshire residents. I understand we're joined remotely by Mel, Jess and Sarah, who have been involved in putting together the Market Sustainability Plan for Wiltshire. So I'll hand over to those three and then we'll open up for questions. Thank you. Have we got...
Yeah, just bear with us a moment. We're just having a bit of technical issue.
Jane.
I was just going to say that I remember having many conversations whilst they get ready with Helen Jones about the importance of communication with your market and market sustainability before it became a kind of a government sort of buzz phrase with attached funding, which you will hear about in detail now. And I know our brokerage team's now commissioning officers. And you will hear more information about that through things like the Good Lives Alliance. But we work very hard in this area as a kind of communication tool. So it's not just about government initiatives. It's a small introduction.
Thanks, Jane.
Thank you, Jane.
I think we're all set up now. Okay, great. I'll hand over to you guys then.
Apologies, it's coming through a little bit smaller, but we seem to be having a few technical issues this morning. Okay, so I just want to give you a bit of background about the Market Sustainability Plan, first of all. So if you can move on to the next slide, please. So in December 2021, the government published a white paper, People at the Heart of Care, that outlined a 10-year vision that puts personalised care and support at the heart of adult social care. Following the publication of the white paper in the same month, the Department of Health and Social Care announced the Market Sustainability and Fair Cost of Care Fund. The primary purpose of the fund was to support local authorities to prepare their markets for reform including the further commencement of Section 18.3 of the Care Act in October 2023, and to support local authorities to move towards paying a provider's fair cost of care. Next slide, please. The government allocated a total of £162 million worth of funding in 22-23, of which Wiltshire Council was allocated 1.231 million. And in 23-24, we will receive 4.269 million of market sustainability and improvement funding. This is to be used to address issues such as low fee rates, social care waiting times, and workforce pressures, as well as continue the work started in 22-23 on fee rates. Slide, please. As a condition of receiving funding in 22-23, local authorities had to submit the following to the Department of Health and Social Care by the 14th of October last year for 65+ care homes, nursing and residential.
Sorry to interrupt. We just have an issue whereby the slides aren't moving on our
Are
presentation.
they
There's
lagging?
Yeah, so we're still on the cover slide, unfortunately.
Oh, sorry. The joys of technology.
Indeed.
I think we're all used to it by now.
That seems to be sorted now. Yeah, yeah, we're seeing the
it
slides
working
moving.
now?
Yeah.
Yeah.
Sorry to interrupt you there. It's a bit
Oh,
slow.
no, that's fine. I'd rather do that than get to the end and then.
Yeah.
Okay, so I'll start that slide again on the next one, please, Mel. That's it. Okay. So, as a condition of receiving funding in 22-23, local authorities had to submit the following to the Department of Health and Social Care by the 14th of October last year for 65+ care homes, so that's nursing and residential homes, and 18+ domiciliary care. So we had to send in an Annex A, which was 2 fair cost of care data tables for those 2 provider markets. Annex B, a fair cost of care report, and within that report, it detailed the cost of care exercise undertaken with full engagement with providers and the outputs and issues with the exercise. It must be noted that the outcome of the cost of care exercise is not intended to be a replacement for the fee setting element of local authority funding, local authority commissioning processes or individual contract negotiation. The DHSC acknowledged that the cost of care exercise supports but does not replace the annual fee setting exercise undertaken by local authorities. Due to delays announced in funding forms in November last year, the DHSC subsequently updated the guidance to state that local authorities would have to submit the cost of care Annex B reports on the 1st of February this year and publish them on their websites, which we duly did. And Annex C, our market sustainability plan, our final market sustainability plan, will have to be published and sent to the DHSC on the 27th of March. Next slide, please, Mel. Thank you. The final MSP must now focus on the following. So an assessment of the current sustainability of local care markets. So that's only for 65+ care homes and 18+ domiciliary care. An assessment of the future market changes between now and October 2025 for each of the service markets, and our plans for each market to address sustainability issues where we've identified them. Our market sustainability plan has been developed by our adult social care commissioning colleagues, provider oversight support team, adults brokerage, operational staff, BSW, ICB, adults finance, and also in consultation with our providers, most importantly of all. We enjoy a mature relationship with the Wiltshire Care Association, and 2 provider workshops were held in the autumn of last year to identify the key messages in our plan. And we are also undertaking further work as we've submitted our draft plan with our providers and internal colleagues. Next slide, please. Key themes that came out of our ongoing discussions with officers and providers that we were touching upon within our provisional market sustainability plan and our final market sustainability plan. Always a terrible word to say. I can never worst one for me to present on. We had a number of joint issues. We were asked if we'd look at care markets separately, but what we found after talking to providers that there were joint issues that they were experiencing. So the joint ones were around complexity of care, inflation, care workforce, so recruitment and retention of staff, is a real issue, both nationwide and within Wiltshire. We have a number of geographical challenges that our providers have. That can be where a care home is situated, or where we have certain provision types, availability of those, and fee rates as well. For care homes, we have an insufficiency of supply of blocked nursing care beds, predominantly in the south and Salisbury area, where we have a number of people going into care over the last 5 years, and it's high numbers of them going in that area. Hospital discharge has become an issue over the last few months for us. And within our domiciliary care market, it's sufficiency of supply where we're having issues. So the next steps for the market sustainability plan will be further engagement with our providers and internal colleagues so that we can complete our final version. We'll be undertaking more work on our fee setting which will include working towards a fair cost of care. Our final market sustainability plan will be published in line with the HSC guidance on the 27th of March. And we'll be taking the final version of the market sustainability plan to Cabinet on the 28th of March. Thank you.
Okay, thank you very much for the presentation. Sorry we had those technical issues at the outset there. I'll just open up to the committee for any questions. No questions at all? No? Gordon's got one.
Thank you very, very much for that run through. So is the market sustainable then after all that?
After me speaking very quickly, Gordon. It is. Obviously, you know, like every other local authority, there are issues. Recruitment and retention is probably one of the biggest ones that we're experiencing. And we have got the relevant funds from the government, the Department of Health and Social Care, to address those issues. So that's what we're currently working through at the moment, with ideas from our providers and internal colleagues as to what we can use the funding for to make sure that we maintain that market and make it sustainable both now and over the next few years.
Thank you. And I've got a question from David.
Yeah, two questions, if I may. Thank you very much for the report. Your reference to block care beds, or words to that effect, is that we're talking about beds that are preventing people being discharged from hospital and therefore blocking hospital, or are we talking about beds that are somehow blocked within the care system where people should be moving out into their own homes or something else? That was the first question. And the second question was, is the money we're getting from the government enough to make the market sustainable? Does it match the need?
Okay, so apologies about the use of terminology. It's an internal, it's how we buy beds essentially. So we buy block framework and spot beds. So block beds we'll buy for a certain price around the country, around the country within Wiltshire. And they're normally a lower price than a spot or a framework bed than we would do. So we normally, through Order of St John Care Trust, we've got a number of block beds around I keep saying country once I've started, now I can't stop, around Wiltshire, that we generally pay a lower price for because they're contracted beds.
Thank you. Different kind of block. And the other question was, is the money that we're getting from the government, or prospectively getting, sufficient to fill the gap that exists in Wiltshire?
It will certainly go a long way to filling the gaps in Wiltshire. Certainly it will enable us to increase the fees that we pay our providers to make them more sustainable in the long run. As you can appreciate, the cost of living crisis that's impacted everybody, it's going to go quite a way towards helping us to maintain our providers and make sure that we have adequate care within Wiltshire over the next few years.
Thanks. And Emma just wanted to follow up on that, and then I've got a question.
Yeah, if that's okay, thank you. Because I think obviously the funding is key, but it's also about how we value care as a career. That's going to be one of the kind of big issues, which is how do we encourage young people, or, you know, people at any age of their kind of working life, if you like, to value and see care as a profession that offers them what they need. So it is that increased professionalism of the service. How do we create a sense of equity or parity with our health service? So it obviously the money is key, but it isn't only about the pay rate, whereas obviously that is hugely important for people. It is about how we're able to offer that career development that I think we need to give as much time and focus to, as well as those financial elements, because in Wiltshire, the rates that we do pay, particularly for an hour of domiciliary care, are already fairly high in terms of other local authorities within the region and nationally. So we need to look more broadly if we're truly to have a sustainable and sufficient care market.
Thanks, Emma. I've got Claire next and then Diane.
Thank you. And I think actually, Emma, you've partly answered part of my question. I think overall, the difficulty is, isn't it, when somebody needs accommodation in a care home, is finding the right place for them without the tangle that they get into around the right funding and maybe being, I'm going to use the word sent, that's probably not the best choice, to somewhere that they or the family don't want to be. I just wondered, at what stage do you think we will have the capacity right in the county so that tangle stops happening? Because I think that causes a significant level of stress and anxiety for families, and not something that any of us really want to see. I guess you've got an idea of when we'll reach that point, what good looks like, if you like. Thanks.
I think it's quite difficult to say when the capacity point will be reached, because what we want to move towards, and we are making kind of significant progress towards, is actually only needing to consider, bed-based care, so placement, whether that's residential or nursing care, where actually somebody can't remain living in their own home, where the risks are so great. Actually, we do need to look at that, alternative. But actually moving towards that position depends on having appropriate community care capacity available and having that kind of degree of knowledge and expertise to be able to support people in their own homes. Because what we will often see is people make that move when potentially they have night, needs at night, and that kind of, what can technology offer us? What are, things can we have in people's homes so actually they can be supported to remain in their home safely overnight? So we're actually avoiding placement until it is really necessary. So it's not only the bedded capacity that is key, it is that broader community capacity that we have to have in place so that we can get that balance right. And this sort of market sustainability piece is going to be one of our key strategies and ways that we can facilitate that.
Thank you. And a question from Diane and then Irene.
Thank you. This is not a question, really. It's just a comment from someone that has worked in social care, care homes, etc., for well over 20 years. And things go round and round. What goes round comes round, and it goes round in circles and circles. And until we actually get some real recognition for the work that care staff do, their abilities, and what they are doing on a day-to-day, then, yes, money is important. It's important to all of us. Without it, we wouldn't be able to live properly. But I don't know quite how we achieve that, because we've not achieved it in the last 20-odd years. But really bringing up what care staff do and making our general public more aware of it and understand it. So it was a comment, not a question. Thank you.
Thanks. And then Irene.
You talked earlier about career progression for care workers, and in another life I used to run short courses for residential care workers, and having got the money to be able to run the courses, it was so frustrating that week by week they would ring up and say, I can't come, they can't release me from work. And so that it's not just what we do for the care workers, it's what's done, what training is done on the importance of training for the care home managers. And that's not just the statutory training that people have to have, but it's the overall, so that they can give a whole rounded service to the residents.
Yeah, I mean, I absolutely agree with kind of both points, and it is back to the importance of the workforce. So within the local authority and our provider services, we've got some really, really strong examples of career progression. We have staff who joined us as support workers in our reopenment service who are now doing their apprenticeship to be occupational therapists. So those are really good examples of where we have been able to offer that and bring people into roles that are actually hard to recruit into. But not everybody wants to do a professional qualification. So it is about having a range of options, whether you do want to become professionally qualified, be that therapy, nursing, social work, or whether you want to, move to being a registered manager. Another area that we struggle to recruit to is registered managers for our care homes. So the opportunities within the sector are enormous and are varied, and it is a challenging role, but it is hugely rewarding. And we know that we have care staff out, in the winter, driving around our communities, doing fundamental roles that keep people safe and well and in their own homes. So we can't overestimate the value of these roles to our communities. I do think that there are opportunities around promoting that. I do think that the public are more aware of these roles and the value that they can add. And also we have the ageing population. So for more of us and our loved ones, it's going to become key. So there are opportunities, but we do have to be more ambitious, I think, in how we're promoting that and encouraging people to join what is, a hugely rewarding profession.
Thank you. And I think we've had, yes, so it's David next, sorry. Bit of a brain fog.
Sorry to intervene again, but now you've said that, I've been thinking all the time, talking about somebody that I know pretty well from my own family, who left school without really very many qualifications at 16 and became a care home worker, but who took to it so well and was so talented at it that she's moved through being a manager of a care home, being a trainer, and now runs an entire region for the YMCA training organisation. And it feels to me like it's one of the classic careers for people who aren't particularly academic at school, but are very good with people skills and very good at learning a whole lot of other really important skills. So I'm just wondering whether there's any, in your recruitment material, there probably is, whether there are case studies of people so that people who are at school can say, that looks like me and I could do that.
Yeah, and we do a lot of work with colleges as well, and we're expanding, where can we go into schools, where can we get in as early as possible and promote it, because I think it is, right that there are a whole range of people out there with a whole range of skills and could come in at different points to the sector. But it's equally important that we focus on people who may be looking at a second career, might be wanting to come back into the workforce possibly, as they're in middle age. So it really it offers something for everybody really, but I think your story is really fantastic, and we do need some more of those that we can take out to say, look, come and join us, and this is where you could end up, and this is what it can offer you really. It is very broad and varied, and I don't think people really understand the variety. We often see pictures, don't we, in the media of sort of older adults and people working with those, but we know with our younger people with learning disabilities or mental health, the roles are really varied, working with that cohort too. So there really is something for everybody. And now I sort of feel like I'm promoting the care industry, but I will take every opportunity to do that because it is something that we really do feel passionate about.
Thank you. And Jane, you want to come in on that?
Thank you. Yes, I wanted to follow up on Emma's very passionate and brilliant, sort of paean in support of care workers, because it is fantastic. People also don't know about shared lives, which is fostering for adults with additional needs. We all know who've foster parents, but we don't know people who are shared life carers, and it's a really fantastic way to make a difference to somebody. And if I could ask you all to just go out and talk to people about that, because there are very few restrictions on who could be a shared lives carer. You can do long term, you can do short term, you can do respite, you can even do day shared lives. You don't have to own your own home, you don't have to be a specific age, you get matched with somebody who you can help, and that again is a really, really rewarding activity, and it is paid as well. So if you could all please bear that in mind and not just talk about foster pet carers, but talk about shared life carers too, please.
Absolutely, yeah. Thank you for that, Jane. Yeah, of course.
So through our work, we support personal assistants to come into the role of care, and actually what their drivers are around relationships and meaningful relationships with the people they support. So I think it's really important to go at it at lots of different levels. It's not always about progression for people, and that's definitely with shared lives. But also, I know in the past we've talked about micro-commissioning. We try and do a lot in people's communities, so to make care attractive in sort of those smaller communities, that it can fit with people's lives, so they don't have to leave their village for a job, they can do it in there. And I think there's lots of different ways we can kind of tackle this issue.
Can I come in? Because Mary's absolutely right. And within the adult care transformation programme that we are, establishing and setting up, those are all the areas that we are looking at, because Mary's right to highlight that there is regulated care and support via kind of an agency, but there are lots of other avenues, and that community focus, use of personal assistance, individual service funds is another area that we're developing. So it is absolutely key that we have a really varied and robust model rather than just relying on one type of care. So thank you, Mary.
Thanks. Any further questions then before we close this item? No, in which case I'll move that we thank the officers for the comprehensive report, and to note the development of the market sustainability plan for Wiltshire. Could I have a seconder for that, please? Thank you, Howard. Any objections? No, that's moved. And thank you again to officers and to Jane for that. And we'll move on now to item 11. This is the inquiry session into challenges being experienced with patient flow through hospitals. The plans for the inquiry session are now taking shape quite nicely. Back in January, we discussed this item and the committee requested a programme to understand how the session would be delivered. So we have provided a programme at Appendix 1 of the agenda pack. It outlines 2 questions for group discussion. Firstly, the factors contributing to increased demand on urgent care, and secondly, exploring how demand could be reduced. Please note that the programme is drafted and will be developed further in collaboration with health and social care staff and the community and the committee. I'm also conscious we need to set a date for this inquiry session, but that will be sort of late spring, early summer, I envisage. So any questions or comments on the draft programme from committee members? Claire, yes.
Yeah, thank you very much. I did send some comments in. I'm not sure that they reached you. I don't know if you've received them.
Gee, I haven't received
It was on Friday.
Ah, okay.
I think there may have been a timing issue that I wasn't aware of. So they may, anyway, just to say that I've sent a load of comments in, and
I think they came by Gordon.
if they could
right?
be
Yeah.
sort of connected up, that would be really helpful. Thank you. Rather than going through them all again. Thanks.
Yeah. No, yeah, we have received those. They came by Gordon and yeah, no, those can be. It was just purely a timing issue. I think we received them after Julie had published the agenda paper supplement. So, but they can be incorporated. Yeah, very much draft, and we can incorporate those, and any other feedback from today as well can be sort of fed into it. Anything else from members? No, in which case we shall incorporate the further feedback we've had, and we'll also publish a date for the session shortly as well. So in terms of resolution, oh, sorry, Claire, go on.
Yeah, I should say it would probably be helpful to have the date earlier rather than later, because I'm aware that there may be some actions that come from the day, and what would be a shame is if we kind of delay setting the day up so that the actions become too delayed into the future, if you see what I mean. Because obviously the impact will be particularly over winter. So, you know, I mean, I know it's always winter, but the NHS and care system, but I think it would be good to sort of make it earlier rather than later, if you like.
Absolutely, you know.
Thank you.
I mean, the reason we haven't had it sooner is that we wanted to avoid the sort of peak pressure period this winter, which we're just emerging from. That said, I'd like to see it happen in the spring rather than in the summer, so that we can perhaps bring a report to our meeting in the summer, and then we're sort of well placed going into next winter in terms of any actions that might come out of it. So I would envisage taking place between this and our next meeting. That would be my hope. So I will move that we approve the draft programme and its further development and publish the date for the session, hopefully to take place in the spring, and certainly I would hope before the next meeting. Could I have a seconder for that, please? Thank you, Gordon. Any objections? No. In which case, we'll move on to the forward work plan. This is on page 25 of the report pack, for a programme which now also includes a proposal to carry out a rapid scrutiny into NHS dental services. This is something I apologise I omitted to raise in my chairman's announcements, but following a request at the last meeting, we had looked at having an item at committee about dental services. However, the ICB, or the Integrated Care Board, are taking over as the commissioning body for dental services in April. So we felt it would be useful to understand current levels of service before considering future plans. So for that reason, we've decided to take this as a rapid scrutiny item. So I would please encourage members to put yourselves forward to take part in that rapid scrutiny, to let Julie and myself know if you are interested in that. So we're updating the forward road programme to reflect that, and also any other changes we make today. So for example, Irene, you had an item on maternity you wanted us to consider.
It was the presentation we had on the maternity services at the last meeting. I forget the speaker's name, but she outlined all the things that they were implementing to create access. Pardon? Oh, thank you. And what I would like is to have feedback at a specified time on how the strategies, the outcome of implementing the strategies, so that we can actually know what difference the strategies have made to the services.
Yeah, absolutely. We can incorporate that into the forward work plan and schedule a program. So that will be added in. Was there anything else? Howard?
Yeah, didn't we have an update on diagnostics provision as well?
Yes.
Wasn't that mentioned earlier?
Yes, it was. It was sort of that at State's point about Gordon's mentioned the diagnostic centre in Peasdown.
Yeah.
And the integrated care centres as well. So
it was suggested it could be an agenda item.
Yeah. So we will include that in the forward work plan as well. Councillor Vigard, David?
Yeah, and have we recorded somewhere the implementation plan for the integrated care that we talked about earlier?
Yeah, that was a resolution, so that will be
that moves into the programme.
Exactly.
And the two briefings you talked about in your chairman's announcements at the beginning, just remind me.
Yeah, so those were sorry, my.
I don't think I've received invitations, unless I've missed them.
You should have done. The whole committee's had invitation. So 10th of March, carers support strategy and service commissioning, and then 17th of March, Good Lives Alliance framework retender. Those are both on Teams, yeah. Diane.
I just wanted to ask, I can't see anything on here. We talked about it last time. I don't know how far we got. And that is the dementia strategy.
Right. Do you recall this?
I remember asking for an update.
That's the kind of thing that's been developed with the integrated care. It's got to be done by.
Just add it to keep it on the plan and the whole work.
I mean, I know that there has been at least 2 meetings so far looking at that dementia strategy.
Yeah.
I just happened to find out about them.
Without wishing to put Fiona on the spot, I wonder. Fiona, dementia strategy. Sorry to put you on the spot, but do you know where things are in terms of the dementia strategy? Emma. Yeah. And then bring that into the work. Perfect. Thank you very much. Did you, Diane? Are you happy with that? So it's.
didn't quite hear what.
So it's early days, but Emma has undertaken to bring an update at an appropriate time, effectively.
I think the other thing was really more about as well, members of this committee, as we have always been in the past, when the strategy is last done, we're actually involved with looking at that strategy as opposed to just seeing what had come from it at the end of it.
Okay, I'll bring Emma in there. Having not been involved last time around, I think it's probably best.
And I wasn't either, so really happy to understand what that looked like and you know, whether there's something we need to replicate. We are going to be undertaking a significant piece of co-production in terms of the refreshed dementia strategy, which is why it will probably take us a little longer than we would have possibly done before, because we absolutely want to hear from individuals and their carers and those wider communities. But I think that's a fair point, and we can certainly you know, be helpful to understand possibly from yourselves and others how that did work.
Thanks. So yeah, I mean, in terms of how that worked previously, what sort of?
Previously, we were sent the strategy when they wanted it rubber stamped at the point when it was finished, and we had a lot of queries about it, and it'd be much more productive to see an early draft so that we can feed back our reactions to it, if there are any.
Okay, so sorry, I'm hearing two different things here now, because I'm hearing from Diane that.
I mean, and I'm looking at Gordon as well, because Gordon and I were definitely both involved, weren't we, previously when we looked at that strategy. And it wasn't just looking at it when it was finished. It was actually being part of looking at that strategy. I mean, I know there have been 2 meetings so far, I believe, with all sorts of partners. And from my point of view, not just from the committee sitting on here, but working in the community, it would actually be quite good to be involved from both those aspects, really, and looking at what's going on. I don't know, I'm just saying. Thank you.
So what I'm gathering from this is that it would be good to see an early draft and then to have the final report brought back to us subsequently before it goes for adoption.
So I suppose I'm just thinking how, in terms of that co-production, we can do that in the broadest sense, which I think is kind of what you're describing, isn't it? In that community input into the development of the strategy, and as we are really keen to co-produce this to get something that is really meaningful and is going to, you know, address our work going forwards, then I think we probably just need to make sure that we are involving everybody in the co-production piece.
That's great. Thanks, Emma. Thank you. Grant, anything else on Forward Work Programme? No, thank you. In which case, I'll move that we improve the inclusion of a rapid scrutiny into NHS dental services on the Forward Work Plan. We add the actions raised during the discussions at this meeting. We add an update on the maternity services transformation from January's meeting to understand the impact of the transformation on services. We add an update on those estate matters we discussed, integrated care centres and diagnostics, and to ensure Health Committee and community stakeholders are involved in the development of the dementia care strategy at an early stage. Can I have a seconder for that, please? Thank you, Gordon. Any objections? No, that's moved, and we shall move on to the next item on the agenda. And I have got my papers all muddled up. Urgent items. Don't think we have any. Stand to be corrected. No, none at all. And finally, then, date of the next meeting, which is sometime away, the 8th of June, 2023 at 10:30 a.m. It's a long way away, but we do have those briefing sessions. There may be other briefing sessions that arise. That's all right. And also, of course, and the inquiry day, I would absolutely hope that has taken place by June, so that we can then feed a report into the June meeting. Yeah, absolutely. Thank you all then. Sorry for the slightly longer meeting this morning. you all in June, not before.